But then there is a question of how much money. How much money do we already have? And I hope that's a conversation we will close, because there are numbers that are thrown around. It's a 600 billion a year sector. It's a 500 billion a year sector. There are quite a number of figures. I was looking at health insurance, and somebody says it's 1.4 billion, growing 8.7% per year. It's about close to 2 billion now, growing to 2.77 billion in 2030. That is just the health insurance market. Private. So how large is the cake? And answering that question is relevant, because if we've lost 80 billion, and I know there is a number like 60, but borrowed money is not sustainable. You have to pay it back. So we should not only look at what was being given as grants, but even count what we get as loans as part of the money we have to replace, because we will have to pay it back someday, and it's not sustainable to borrow our way through generations. And another important lesson from history: there is no country that is ever developed by foreigners. If they do, they are doing it for themselves. And that's something important to always remember. There is no single country, and you can look across the entire world, that is ever developed by foreigners. When they do, they are settlers with no intention of ever living. And you can look at examples globally. What foreigners have done, or foreign knowledge or capital has done, is to be used by local capacity that knows where it wants to go. Are people who know what they want to do, and they seek external help to meet their needs. Whether you're talking about Mali, many centuries back, or Baghdad, those centers of historical learnings and growth, you'll always see that there was foreign capital and foreign knowledge that came to assist the locals to achieve things they wanted to achieve. But it never worked independent of local intention, objectives, and vision. So as we look for resources, it has to be resources that come to feed and help us to achieve our goals and needs. So if we have a 600 billion, and I hope the health economists will tell us the number, and if they don't know, Strathmore will help them to work out that number, because it's an important number, right? Because if it's 600 billion, then how much is 60? 10%? Maybe we could simply do some efficiency gains by, changing a few things. If it's 200 billion, then the gap is much, much bigger. So we have a funding gap, and it's very significant, and it's had very disruptive impact. But it needs to be seen as a bit of a whole, so that as we look for compensating mechanisms, we know how deep we have to dig to fill that gap. And there are several ways of filling that gap. One of them is to get more money from our treasury. And we have to make a case, and that's extremely hard work, because there are many, many competing needs. The next is social health insurance. And you know what's going on with social health insurance at the moment. SHA is struggling to get the informal sector, or the non-payroll sector, the non-captive. Let me call it the non-captive sector, because I'm a captive. All of us who are on a short leash because you're on a payroll, and all KRA needs is to tell, or anyone who wants more money from you is to tell your employer to take it out at the pain of a penalty. We are captive. The non-captive sector has been a struggle for not just SHA, but anyone else who is trying to get them to carry their burden or their fair share of the national burden. And we have other pockets. We in the health sector subsidize the transport sector. Every vehicle on our roads is insured, third-party insurance. They actually don't pay the medical bills. That insurance the money doesn't go to SHA. I can tell you it doesn't come to hospitals because I'm in a hospital, right? And it's a very tedious process of trying to get claims to go through. There was an attempt some years back to introduce a no-blame compensation arrangement where some money, like what happens with airlines, right? Because we need, for those who suffer injury, they cannot wait for 5 years for a judicial process to end so that they can be compensated. We need to find a secure but much faster process of doing so. We have a road levy. Some of it should be coming to health because one of the consequences of having roads is accidents. And we should be getting a share of that money. But getting more money is not enough. And from both corporate and personal experience, somehow expenses seem to keep rising as you get more money. And countries and companies and individuals have to constantly seek ways of optimizing that finite resource. And the health sector is no different. Our highest return on investment is to do a lot more prevention and promotion. And that space is space that is best occupied by counties and the national government. But we need to differentiate between being responsible and doing. Because it's only in health, I think, where the government not only feels it has a financial responsibility, but also feels it's got to do the doing. In roads, we hire contractors. In most other sectors, we hire experts to do the job. In health, the government also wants to be a provider. And it's important that as we look at the sector, we establish who has the lowest per unit cost of doing anything, because that's a person who should be given the money to deliver the service. If it's a faith-based hospitals, so be it. Let them get the money. The rest of us will need to find something else to do. If it is a private for-profit, let them get the money and let no one deny us our hard-earned, well, whatever you may want to call it, right? Because we'll have earned it. We need to move away from ownership to output. You know, there was an argument not too long ago about whether Aga Khan or KU does, what is that scan? PET scan at a cheaper rate. And somebody said KU is cheaper because they charge 50,000. But the machine cost us. We paid for it, then they charged 50,000. Aga Khan machine wasn't paid for by us, and they charged 75,000. So if you really run the numbers, it may well be that we should send everybody to the Aga Khan and thank them for saving us national resources. Because we need to look at cost holistically, not just the cost the user of service pays, but the entire cost to the economy of providing a particular service. And to do so, we are fortunate that this country is known as a Silicon Savannah for good reason. We are very, very good at building ICT systems, at digitization. And through those tools, we can improve accountability, even at personal level, as a doctor, as a nurse, as a healthcare facility. We can find better ways of collecting money from those. The non-captives can be made captive a lot more easily. And we therefore must fully deploy ICT across the entire sector. As far as I'm concerned, it's a glue and the catalyst for the sector. Whether you are talking supply chain from factory to patient, or the financing cycle from contributor to service delivery, whichever pillar you look at, ICT can make a transformative difference. And we need to use it fully. Finally, capital is shy. It doesn't go to places where there's a lot of noise, war, chaos. You know, business likes predictability. We therefore must tone down the noise in our sector. If you read the history of the Ottoman Empire, it went down because of civil wars between siblings who wanted to take over the job. We too, if we have constant civil wars in the healthcare space, if we do not take an all-of-sector approach and see everyone as an important player who has something to bring to the table, and we are constantly throwing brickbats at each other. Hospitals steal money, 40% of the money just goes to fraud, waste, and abuse. SHA is a thief that's taking money from Kenyans. Who is going to put money in SHA if the message is that you will not get care and the only thing they do with it is to eat it, for want of a better word? Who is going to come to a healthcare facility or invest in a healthcare facility or lend it money if the message is that the claims it gives to SHA are nothing but fraud? We need to raise our trust capital. And for me, it's the most important capital we need in this space at this time, because the cost of complexity is probably the 10% we need as efficiency gains to fund the gaps that we have now. Because as it is now, we are increasingly building more complexity whose purpose is to manage the distrust we have within the sector. So let's work on building our trust capital, even as we strengthen the traditional 6 building blocks that we have in the sector, and use the lessons we learned from COVID, that you need an all-of-society approach to address the health system's challenges, not just the health sector alone. Thank you.
Thank you, Dr. Gakombe. You have told us how disrupting the funding cuts have been. You've also told us how deep we need to dig, but you've also shown us where we need to look for this money and what we need to do in terms of governance so we can keep this money. The timekeepers are telling us we are running a bit slightly behind schedule. So I want to invite the moderator for our first panel today, Rose Nzioka, the country director of Palladium, to come on stage so you can invite the panelists for this session. As you do that, just to give you a bit of a background of what this panel session will look into, I think Dr. Gakombe has spoken about many things. So we want to look at the evolution of that health financing landscape. We want to see the journey that we have traveled this far, what it takes to build a country-led, shock-resilient, and system to protect our maternal and child health, to address infectious diseases, and to see what we do in terms of our primary health care. Rose, I'll invite you on stage. I'm waiting for you to come up so I can sit. Once you come up, then I'll be able to take my seat. So I'm buying that time. So I think the conversation that is ahead of us will help us to see how we waive this case for predictable financing. So Rose, over to you.
Good morning, everybody. Thank you very much, Doreen, and the past speakers for laying the context of what we'll be discussing in the panel today. The Africa health system has really improved in the last several decades. I think we all are aware that many of our global health indicators have been on an improvement path. Our maternal indicators, our reproductive health indicators, our child and neonatal health indicators. But as previous speakers have told us, that has also been interspersed with lots of challenges. And one of the challenges has been donor dependence. I think it's been clear that the aid model is broken. And therefore, what we are going to be exploring in this panel is, how did we get here? How did we get to the situation that we find ourselves in? I think it's Doreen that said, you know, we are now at a situation where funding has been withdrawn, you know, by many of our donor partners. And KHF chair has told us that, you know, nobody is coming to save us. So as Africans and as Africa health systems, what do we need to do in this situation that we find ourselves in? And therefore, this panel will be exploring how we got here. What is the path that led us here? And what are we doing as a community, as a continent, to recover from where we have found ourselves in? Aid was supposed to be a bridge, you know, to get us from the many challenges that we were having in the Africa health sector, challenges of emergencies, conflict, lots of heavy disease burden in many disease programs. But we have found ourselves seated in that bridge. You know, it was supposed to be a bridge to resilient health systems. So we'll be asking ourselves the question, how did we get here? And what are we doing to bounce back? What do we need to do tomorrow? What do we need to do going forward to ensure that we are addressing these issues? So I'm going to call our esteemed panel to the podium so that they can walk us through, we can have this conversation. And I'll start with Dr. Anne Musuva. As I call you, please come to the podium. Dr. Anne is a health systems specialist with over 15 years experience in strengthening health systems and in designing and implementing public health and health financing programs. She's worked as previously the country director for ThinkWell, Kenya, chief operating officer for PSK, where she successfully managed multi-million-dollar healthcare programs. And Anne serves in various committees as well as KHF, where she has led key committees. Next, I'll call Dr. Paul Nyachai. I don't know if Paul is here. All right, I'll move on to Dr. Newton. Paul can join us when he gets here. Dr. Newton Omale is the head of grants and partnerships at NASCOP, Ministry of Health. He's a public health professional with over 20 years of experience managing HIV, TB, malaria, and health system programs. He currently leads Global Fund, CDC, and PEPFAR grant portfolios and drives HIV integration and sustainability planning for NASCOP. Dr. Omale is skilled in strategic partnerships, proposal development, and donor coordination. Next, I'll call Dr. Daniel Mwai. Dr. Mwai holds a PhD in health and environmental economics under the African Economic Research Consortium. He is a recognized thought leader in health policy and financing. He has over 15 years experience and has advised the Ministry of Health on financing for the last 6 years, overseeing a mobilization of over 600 million in the health sector through the national and county level budgets. Next, I'll call Dr. Elizabeth Wangia. Dr. Wangia is a dedicated health professional with extensive experience in health financing, public health, and clinical research. With a strong background in emergency medicine and epidemiology, she has held various leadership roles, including the Director of Health Financing at MOH. Our commitment to advancing healthcare policy and primary healthcare is evident in our work with multiple organizations that have included the World Bank, where she currently sits, and the Kenya Health Institutions, as well as WHO. All right. I'm told Dr. Nyachae was replaced by Elizabeth Irungu, if you're here. So Elizabeth Irungu will be representing Paul Nyachae, who is the country director for JEPIGO. So Elizabeth will be speaking to us about implementation level interventions and what is going on in that space. Thank you. All right. So to get started, ladies and gentlemen, I'm going to start with Dr. Anne Musuva. Dr. Anne, you have experience both at the public sector level and private sector. You've done lots of work in PPP partnerships, and like we have said, you've supported health reforms, especially in reproductive health and maternal health. So you bring a unique perspective. So from your experience working across different levels of health system, how would you say the history of global health, coupled with the volatility in global health today, has shaped the way health policies in Kenya and other African countries are designed and implemented?
Thank you, Rose. Yes. Thanks, Rose, and thank you to Strathmore for having me here. It's always a special place to be. I studied here and met my permanents over here. So it's nice coming back here. But I think what you're asking, Rose, is so critical, like tracing the origins of global health, the history, and how we actually got here. So if you go down memory lane and we try to trace the history of global health and where all this started, we can actually trace this back to colonialism and to former individual governments. When we had the colonialism coming to Africa, to Asia, and they encountered very many diseases, malaria, yellow fever, and so on. In the Africa Gold Coast, what is known as Ghana, 30 to 70% of white settlers actually died from the diseases that they found there. So this whole conversation of tropical medicine, these are really the beginnings of global health. In the 19th century, we really saw an expansion of trade, of economics, and with it, the movement of people and also the movement of diseases. In the early 19th century, for example, we had 6 cholera epidemics. And this led to some European nations, about 12 nations coming together and starting to discuss what do we do about this spread of diseases across countries, because this is really what global health is, addressing health issues across borders. In the 1940s, we then saw the formation of the UN and then the WHO. And its main mandate was global health issues to manage and control the spread of infectious diseases, again coming from these colonial origins. In the 1990s, we had the HIV epidemic. And I think this was really pivotal in terms of galvanizing international cooperation around managing this epidemic and others in future. We then saw a trickling of a lot of foreign aid to countries in Africa and Asia and so on. We saw the formation of PEPFAR, other global health initiatives such as the Global Fund to combat these diseases. And if you look at this entire history, a lot of it has been focused on infectious diseases. Now, when you look at the policies in Africa, up until this time, a lot of them, again, have been focused on what these trends have been. So in infectious diseases, for example, So we spend a lot of time setting up systems, policies on HIV, on TB and malaria. And I dare say at the expense of other conditions such as non-communicable diseases, neglected tropical diseases that perhaps are not crossing borders as these other diseases. So a lot of our policies have really been focused also on this when you look at this history. With it has also come a really fragmented system of our health systems. So I remember when I was working in the public sector at Mboni Hospital, and I was approached by a USAID-funded organization to support me to set up a HIV clinic in my hospital. And I was told that I need to set aside a special room. I already had about 100, 200 HIV patients. And I said, why do I need to have a special room? And I was told I'll not receive the support I need unless I set this special room called a CCC. Now, all of us that have worked in the public sector have seen these special rooms. And these are not just infrastructure or buildings. We also have very fragmented supply chains. So we have KEMSA, but we also have, different donors. You'll have Global Fund with their own supply chain. You'll also have other donors, each of them with their own supply chains. I remember visiting a facility in Isiolo a few months ago, and I was just looking at their supply chain records. And I saw that within a span of a month, they had received deliveries on nutrition commodities from 4 different entities. So this is the waste that we're talking about. This is the fragmentation that we've talked about, that we've come to see. But I think the past 5 years in particular have been really pivotal in us starting to shift and see things as they really are. I like what Dr. Gakwambe said, that nobody's coming to save us. And I think we saw that very clearly in 2020 when, when we had the COVID pandemic, where all global North organizations faced inward and, of course, were more concerned with their own citizens, perhaps as they should be. But anyway, and here we were waiting for someone to come and save us, as we had seen in the past. But I think this time round, and I think we saw very clearly that when countries are pushed to the wall, ultimately, they are interested in inwards, right? And so Africa was left as scrambling. And the AU and the Africa CDC then started having discussions around, how do we change as Africa? What needs to change? And this is when we saw policies such as the new public health order by Africa CDC, which some of the pillars are, for example, around domestic resource mobilization, local manufacturing on the continent, leveraging on private capital, and so on. And now this year, I think, has really accelerated all these discussions, right? With the Trump stop work order, and many other countries, not just the US, following suit. We are also seeing European countries, the UK, and so on, and we are really starting to see aid declining overall. And so I think where this places us right now, and the policies that we are starting to see, is really us starting to look inwards and starting to think critically around what do we need as a continent. So I've seen, for example, now there's a policy going around on integration of health services. So away from these standalone CCCs, standalone supply chains, standalone data systems, and leveraging all these strengths that all these donor-funded programs have provided the health system, but utilizing them so that the entire health system can actually benefit from them. We're also starting to see discussions around efficiencies, albeit I would say that this is not as advanced as I would like to see, but we really need to have efficiencies around the health system. The reality is that the resources that we have are finite. And even as we have the discussion on domestic resource mobilization, all the other sectors are also competing for the same resources. And so the discussion on efficiency, how we are utilizing the already limited resources that we already have, is absolutely critical. So efficiencies, for example, in also how we are allocating resources to primary healthcare, and I'm very happy that the Social Health Authority, one of the funds that we have there, is on primary healthcare. But we also need to talk about efficiencies across other systems, supply chains, IT systems, around human resources for health. A number of studies show very high absenteeism rates, across the continent, where about 50% of health workers, are are not working at any time, and we know this is our biggest resource. So let me pause there, Rose.
Yeah, thank you. Thank you so much, Anne, and those are great, great points. I think you've just interspersed as well, what Professor Frank was unpacking for us about the disjointedness in the system, the parallel solutions, the systems that are not speaking to one another, and broken supply chain systems, etc. You've spoken about the need to focus on efficiency. And I want to ask Dr. Wangia, you've had a very unique perspective working within the government as head of financing. On the other hand, you moved on to WHO as advisor on health economics, and now you're at the bank advising on health economics as well. So you have a 360 view. Dr. Anne has talked to us about the need for efficiency. Maybe can you, in your view, tell us how has external influence over health data influence what gets measured, what gets funded, or what is ignored in Kenya? And how has that shaped the trajectory of health systems in Africa? And what do you think are the consequences of sidelining evidence in favor of political expediency?
So thank you so much, Rose, for the question. And once again, thanks, Strathmore, for the invitation. It's an honor to be here. Regarding the question on really how external influence how external funding has actually influenced our data and the like, I would want to point out two main areas. First of all, the common saying that he who pays the piper calls the tune is what I would that will be my explanation more or less on the impact of the donors when it comes even to health data. We have seen, just picking from Anne's point on HIV management and how the donors actually came in to fill in the gap. It was a good thing because we were really in a bad position, but what we saw over the years, is that there have been parallel data systems. If you look at the system for HIV, we have had parallel data system for reporting for HIV, for reporting for TB, malaria. In some cases, the donors have also taken part in, coming up with the system, for example, for human resource for health. And what this results in is, one, as a country, many times we have no access to this data. Number two, since these systems are really strong, it tends to portray also that the burden even of a disease could be higher. And I'm not saying HIV is not a burden, but the more a condition is reported, the more priorities are given. And even in the global, if you look at our global data, HIV still tops the list. Sometimes I believe that probably there could be something else. But since HIV is what is reported, is what we keep on seeing. We have also seen the more that we have reported on things like cancers and other NCDs, we have all of a sudden started seeing that they are emerging. I don't believe that was the case from before. I believe that probably we started, the burden of NCDs was there from maybe a while ago. It's just that previously it wasn't that much reported. So, and largely most of this, especially for HIV, TB, malaria, I know Newton is here, it's mainly been around PEPFAR and Global Fund. They really influence. And I really like what the government has taken up right now with the digital, the ambitious. Let me put the word ambitious. I know Dr. Mwai is next to me here, but it's an ambitious digital agenda. And at times as a country, you need to be ambitious. And when people think that maybe this is too ambitious within yourselves, you believe it and you start making steps. And right now we know that we are within the digital superhighway, we are trying to bring all data systems together, bring about interoperability, and even constant sharing of data amongst each other. The other thing about that is closely linked to the priorities, where the priorities are, is fragmentation and siloed data. That is it has been very rampant. And as I said, within the digital superhighway, we're really hoping that would really come to save us on that. And what does that influence? It also influences research. As a country, if we are to research on something or the burden of disease or situations that really affect us, then we really need to have the data. And therefore, once we have all of the data in one place within the digital superhighway, then we may actually write our research agenda, and we may be able to actually focus on whatever research and therefore inform policy. The question you asked around the influence of politics, one thing I would like to applaud, say, the leadership of this country, is that they have really tried, I think over the last 2 or 3 elections, to involve technocrats when it comes to building the manifesto. And whoever wins, and you'd see during campaigns, each side will always get a technocrat to promise 1 or 2, 3 things. And therefore, somehow, the technocrats will actually guide based on the policies, but that's not the case in many African countries. In many countries, you'd find just promises, there'll be promises for free this, free that. Then now, when it comes to implementation of those promises, since those promises were made without evidence, it becomes difficult to influence. So my take is that we should, as health people, we should not distance ourselves from politics. The reality is politics are here with us, and they also run the show. So the question is, how can we bring in our technical expertise into the politics and actually guide them? Because a politician will tell you they want this, but then you can tell them this is the technical aspect of it, but you can look at it. If you want to look at it politically, you can still gain by this and that. So that way, there's a win-win. Yeah.
Thank you, Dr. Elizabeth. I think I totally agree with you that we can't ignore politics. Politics drive agendas. They drive health agendas and even other agendas, and that's how we've ended up having, the Trump administration's foreign policy. I mean, that's a political decision if you look at it, but we can't run away from the politics, but embrace how can us as technocrats influence political decisions that are made. I like the point you brought up about strengthened data systems leading to numbers looking higher than they ordinarily are. I think most of us know somebody that either has cancer or has a relative that has cancer. And I think, like you've said, a lot of this, even though the cases have increased, a lot of it has to do with reporting as well. The more you report on a disease program, the more you bring it to visibility. Just pivoting a bit, Dr. Newton, you find yourself in the intersection between global priorities and government programs. Maybe if you can walk us in your experience how you have seen political priorities, both global and national, shaping allocation of resources within African countries like Kenya.
Okay, good morning, and thank you for the question. Yeah, I'm happy to be here in Strathmore, and for those who don't know, I was in Strathmore first in 1999 as a student here. Yeah, and I'm happy to be here. I came back in 2023 again as a student, and graduated this year. So thank you, and thank you for your question. So the question is about actually politics and aid, and for all you know that like you just said very well, that the political agenda influences the health resource allocation. We start at the global level with what has happened this year, and we all know that the President Trump, the US president, has a whole shift in the way he views foreign aid. The foreign policy has really changed. So this has been a very interesting year. I've been called more than many times to write a CAB memo. What are the impacts? How is the government going to respond? What is being affected? What can the government do all the time? So, I don't know if I can pose a question. What would be Trump's main agenda? What does he want to do? He wants to win a Nobel Peace Prize. but he didn't win. But what is his agenda, number one? Where is he spending most? Somebody? Where is Trump's government spending most? Isn't it military? Yeah, I was shocked to see some numbers with the military spending in the U.S. There's a one plane that costs $20 billion, the B-2 bomber. It's one plane is about $20 billion, but that is a little amount of money that the Africa needs just to make sure that its health systems work. But that's what they use for one plane. So the foreign policy definitely has changed how we are being funded. There is no longer USAID. USAID has been disbanded. You know that there is no longer PEPFAR. There is no longer CDC. He has deprioritized all that. Now we have the Global Health Security Department, and that is what is being advocated by the government. We are going to see this week, between this month, Kenya is one of the first 3 countries that have been earmarked to sign a G2G bilateral agreement between the US government and the Kenya government for health. So we are signing that in the next 2-3 weeks, where foreign aid is going to be government to government at the global level. You have also seen at the global level the deprioritization of some multilateral agencies that were really, really critical in the fight for disease. There is the WHO. You know that the Trump government has deprioritized WHO, is no longer funding WHO. There is the UNAIDS. UNAIDS is going to die soon. Why? Because Trump does not think that it should survive, you know. So there is all that, and what has happened with the global health security now affecting Kenya is that we no longer have the money just flowing as official development assistance, but it will be bilateral, government to government. So in Kenya, what has been the effect politically of all these shifts is, you know, that we have the bottom-up economic transformation agenda for the government. Wherever the president goes, and Mwai is here, you can say, the president knows so much health, I get shocked. I think he's advised very well by Mwai and company here. He knows so much about health, and if you look at the previous governments, the Mwai Kibaki government, the Uhuru government with the Big Four agenda, and now the new Ruto government with the better agenda. I think this is the first government in 2023 that enacted 4 laws. There were 4 laws that were actually enacted, and somebody was telling me that if you have a decree, you remember the days of, I don't know what generation I am, Gen Alpha, oh, geriatric. Thank you, Art, for reminding me. So, yeah, so you remember the days of Moi, where he could make a presidential decree. Somebody told me that however many the decrees the president makes, without a law, then there's nothing he's saying. He's actually just lying to the voters. But this is the first government in 2023. We had 4 laws enacted. The Primary Healthcare Act, we had the FIF Act, the Facility Improvement Act, we had the Social Health Insurance Fund, and we have the Digital Health Act. All these were enacted into law, and we can see that there's the whole issue about SHA and UHC is actually politically motivated. If you go to the president's desk now, I think one of the main issues is SHA must work. Yeah, SHA must work. So maybe I can stop there because of time. Thank you.
Yeah, thank you so much, Dr. Newton, for unpacking all that for us. Maybe as a follow-up to what Dr. Newton has raised, Dr. Wangia, regarding the G2G funding, which is emerging as the new funding model. Do you see, an opportunity that will improve transparency, and therefore maybe it will improve resilience in the long term, because we have also seen that donor-funded programs, most of the time, the budgets sit outside the government, and there's no visibility. There's looking into what what this budget, the expenditure is like, especially at the project level. Do you think there's an opportunity for improved transparency and therefore improved resilience in the long term?
Indeed, I believe so, because one, the government, if I may speak about the government of Kenya, it has quite a number of systems in place. Part of the things that the donors used to do is to move away from those systems. And when you use a system, that's when that system can get better. So in my view, this G2G approach, of course, will be a good idea, because one, there'll be the systems will be strengthened further. And, if I may if you look at the funding from the US government, actually close to 60 to 70% of the money from the US government previously was going through intermediaries. So at the end of the day, we'll manage to get the 100% allocation, hopefully. We can't believe in 100% efficiency, but even if there is 80% efficiency, it's still not close to 70% that was being used as management fees and the like. And I believe over time, with better accountability systems and structures, things will get better. It may not be better at the beginning, but in the long run, the systems will be strengthened. Yeah.
Thank you so much. Let's pivot just a bit again and look at the front line. So Elizabeth, from a Japaigo perspective, in Kenyan street lingo we say, kwa ground mambo ni different. So maybe explain to us, how have these funding cuts impacted what is done on the ground, and especially what are some of the impacts of these drastic reductions, and how are implementing partners evolving and coming up with models that improve time resilience?
Thank you very much for the question. So, truth be said, we have truly benefited from external aid in the programs that you have listed for HIV, for TB, for malaria, for family planning, and even things, cushioning the health delivery, the laboratory systems. We had an extensive health workforce that was paid through these funds. And then stocks, commodities, products, programs, lots of things that were paid through donor funding. And so the abrupt cuts caused chaos. Very quickly, everybody knew that people have lost jobs. People would go in and seek ARV medication, and you want to get as much as you can because you don't know how long we will be before we get there. So I think the abrupt cuts caused a lot of problems. But I think importantly what they have done is that it leads to an erosion of trust for the ordinary Kenyan who was used to going to a health system and finding a nurse or a provider there ready to serve them, or for or medication available, or being able to do a HIV test or a viral load seamlessly, as had been in programs. And now you go in and it's not there. So you kind of get back to, we're eroding the trust that the system, that the healthcare, that the Kenyan had on the health system, and that will take a while to build up. But I think it is important to state that aid still matters, even at this point, in whatever form it will come. First, we talk about self-sufficiency, but I am not convinced that any country is truly ever self-sufficient. It's truly ever that we do not need the neighbor, or we do not need help. And we also are support for other countries. So the rethinking what we mean when we say self-sufficient, I think is more partnership more than anything else. It's partnership with governments, with other governments. It's partnerships with donor organizations. And that these partnerships should take cognizance of the fact that doing an abrupt stop of funding creates chaos. and that's not the way to do it. By doing something like that, then you disrupt, where, for instance, there had been promises of so much money for family planning, and half of that drops, then government has to provide these commodities, but was not planned for. And so you end up going into the market to purchase product at now a much higher cost than would have done if it was not anticipated. So it rolls off into a more expensive and costly affair than just you need to now go and buy your product. But I think there also needs to be recognition, and was alluded to by the keynote speakers earlier, that there are things that government may not have appetite for right now, and yet are absolutely critical. I think about research and innovation that are important to build our systems to be better systems in future. So at this point, for instance, government is more interested in, can we get our populace the product they need, the treatment they need, the care and prevention they need? But perhaps research and pilot studies are not at the top of their list. And so for things like those, I think aid is absolutely important, and it needs to be catalytic rather than substitutive. So we're not getting aid to come and do what government ordinarily needs to do, but perhaps do something that's more catalytic. We have an innovation. How are we going to test whether one model is better than the other? I don't think government will have the capacity to say, oh, let us keep aside this money to do research while we have people who need treatment. But that kind of risk would be taken up by aid when we ask for it and ask for it well. But I also think we need to do better. We have had inefficiencies. Truth be said, our NGOs have had lots of inefficiencies. We call people out for training, we give them per diems, we do many nice things that are not within government. And part of that is because you're reporting to a donor need. They need these results fast and quick and reported in this way. And so this is an inefficiency that perhaps we now have an opportunity to move away from and begin to work within government structures. However slow government takes to get that training done, or however slow government takes to get that reporting done, like Elizabeth has said, once we start working within the system, you get to improve it. And so I think that as bad as this looks, perhaps it is an opportunity for us to get to do better. We do not need to be extravagant. You would go to a health facility and find 3 USAID vehicles from different NGOs, all doing different things at the same time. And it's quite a bit of inefficiency, but yet the donor sets the system that way, that this is how we are going to do to be able to gain results. And so I think finally just one comment regarding the political angle. At a meeting we had not too long ago, what's his name? Dr. Nyikal. Dr. Nyikal was very quick, and he said something, and I think he'll allow me to state this as he stated it. He said that PEPFAR, institution of PEPFAR, was really a political decision. And the stop work orders are truly also political decisions. So whether or not we get funding is a political decision as we talk about technical aspects of it. And so how do we talk to the politician in Parliament today to be able to avail the resources we need for health? And he does not want to see a 20-page brief. I think the politician wants to hear, if you put this much money, you have this much cost saving, you look good to your constituency, and you get your vote back next year. If there is a way we could message this to them, then I think we'll begin to address the challenges that we have. Thank you.
Thank you. Thank you so much, Elizabeth. I think you bring very key points there, especially around the fact that we have to message better. I think we've agreed that politics cannot be divorced from funding, and therefore we have to message better so that our political class, we help to build the case for our political class to be able to invest in health as an investment. I think another point you've brought up is on the whole reporting and inefficiencies, and sometimes these inefficiencies are not random. I think, and it's Dr. Wangia also was talking about the inefficiencies in how we have utilized budgets. Sometimes budgets supporting project management, as compared to outcomes. So I think those are critical points that we have to look at. Dr. Mwai, coming from implementation, you know, having worked with you in Palladium, yeah, where you were an economic advisor, a health economist, and now working as an advisor to the presidential unit. In a context where health budgets are shrinking, like we have been saying here, and donor priorities are shifting, what bold reforms should African governments pursue to ensure that we are insulating our health systems from political cycles and ensure that there's continuity of achieving these great outcomes that we've been speaking about?
Yeah. Good. Is it a morning or an afternoon? I think I have been to so many places. I was thinking it's in the afternoon. But thank you very much for having me here. I think this university I taught for quite some time in the master's program. I have seen a lot of my students here actually, so that's a good thing. But having said that, I want to highlight some few things, and I think from where I look at it from is that while it is not good that Trump have cut funding for Africa, I think it's painful, but it is sending a little signal that financing that is dependent on donors will one day come to an end. And I think when I worked for Futures Group, I think that was 2012, when I returned as a graduate of health economics PhD, I was hot, and I felt that it is important to change my nation. I wrote a paper on value for money for malaria investment. When we looked at the value for that investment, Lily, when we calculated, there was no value for money. We published the paper, and because Satan has a way of working, that paper traveled all the way to Congress in the US. And that time, it became extremely political. That we have said there's no value for money for the donor funds that were pushed to the country then. Of course, we didn't say it was zero. We said we can get better value with those resources. It almost costed my job. I spent 6 months defending myself. And those we worked with in government, in the donor community, they jumped the ship. They said that is a fellow who has written, We were not well consulted. Now, that time, when I look back, I see the fact that the African systems and government must want to hear the truth. Like, you need to know where am I before I start moving. Now, because the people who have been making decisions for long, unfortunately, are those that have been funded by donors themselves, and therefore those who pays you determine what you say, even if what you say is not what it is. You must make it get close to your truth than yours. Now, that is the healthcare system we have learned over the time. So the first point is that we must tell ourselves what it is. Now, the second thing is that because of that, we architectured a healthcare financing system that is the funder. The system does not respond to our own needs. Our solutions are not merited to be serious and good solutions, so we copy what is working out there, regardless of whether it works here. Fortunately, it always don't work. So we have a problem, and the problems persist. Now, from what I look at it from there, is that the African nations, including mine, must have a realistic view into their healthcare financing architecture. And I see a lot of government should allocate more money. It's a nice thing. I was one domestic resource mobilization advisor for 6 countries in this region. Now we have no money. That money you're asking does not exist. Now, it is very easy from a novice area to think about the budget of a 4 trillion that is within Kenyan government and all the others. But if you want to only look at your lens, then you realize that there are other problems than your healthcare sector. And the people in government sometimes don't actually value health the way we in the health sector value. Like, health is very important, it should be funded, it is very nice, that's very good. But that music is only in this room, which I'm sure 90% of the people work in the health sector. All right? And that 20 do not have influence in government. So therefore, there is no allocation that will come out of this place. So we target the wrong people, and we have a way of thinking within the healthcare system that our leaders understand. They don't. And we also have a lot of way of thinking that they care about the real things. They don't. Because they care about what they do know, and that's what is important for them. A case good example, for instance. This country, density for facility, I think, is now around 2.6%. When you look at it, the WHO level is around 2%. But we are still building hospitals. All right? So where there is a level 4, you want it 5. But the 4 was not even a 4, it was a 3. But the 3 was not a 3, it was a 2. But now, what are we interested in? Is it the investment of brick and mortar we see the building? Or is it the services that are inside those facilities? Now, and I like what Dr. Kakombe have said, if we are making noise, we should be making noise to make sure there are services inside our facilities. We should make the people know seeing a level 5 written is not important at a level 5, refer or teaching. When you go there, there is nothing to refer that can be done there. There is no teaching that can happen because there are no human resources in there. There are no equipments in there. But we are not talking about these things. So the health sector within our African context must also have people, professions, who know what is right to actually push for. Because we have long investment that are not addressing our priority. The last thing that I want to say on this financing, there is no ecosystem that will be sustainable if we don't invest in prevention and promotive. I am one who believes that the only healthcare financing system that is sustainable, the only strategy is actually prevention and promotive. That will at the largest cost. The second thing is that we must stretch our shilling to do more, all our dollar, pound, land, whatever we are using, to do more. But how does it do more when a private sector, probably not owned by Dr. Kombe, is a good man, but owned by another person, is charging a sewage for 100 shillings after buying it at 50 shillings. Sorry, at 5 shillings. 20% times. I want to see that margin can be justified how and in which market. And of course, the spirit of integration. What do we integrate and what should we not integrate? The HIV program gave us a very important metric, which is equity. It advanced a lot of equity in service delivery and access, for instance, for populations that ideally are left behind. Key populations, for instance, being at the lead. With the removal of donor funds and illegal, having classified some of those investments illegal, so to speak, I really think there is a problem that we need to dive into without hypocrisy or wanting to believe that the problem does not exist. I want to stop there, but I also want to say that Africa funds inputs. And go sit down, play. That inputs will generate output. There is an avenue to fund health within the output-based mechanism. So that you pay for output and not just push 2 nurses into a facility, send an equipment which is kept outside the building. There is no person to operate it. There is no medicine. Then you sit down, you expect that health indicators will improve. That's what we do. We must get a way of linking our inputs or investment to the outputs. I can say more, but I want to stop there.
Thank you, Dr. Moy. Very great clarion call on what we need to do. I guess we shouldn't speak to the converted all the time. We need to think beyond us as health and think about the sector. And because we are running out of time, I want us to go to the parting shots for each of the panelists. And as you reflect on the conversation that we've had here, think about if we were to meet here again 5 years from today, and this transition has failed. You know, we still have parallel systems, we still have donor dependence, we still have disjointed systems. In the words of Dr. Moi, we are still counting inputs instead of outputs. What is the one thing, in your opinion, that will have failed? And how would you suggest we handle that? Please use 30 seconds, starting with Dr. Musuva.
I think what would have failed is us failing to be responsive to the needs of our populations, because this is what we've seen in over the past decades with the influence of aid, where we are focused more on the priorities of donors and not of our own people. So I think we need to completely dismantle all that, have a blank sheet, and look critically at what are the needs of our populations and start from there with the limited resources that we have.
Thank you. Dr. Newton?
Okay, thank you. My parting shot is that we must reframe the narrative. We look at health as an investment, not a cost. So we need to use simple local data to show how investing in health will improve workforce productivity, it will improve the education sector, and it will guarantee the politicians, the voters, healthy voters, voters that are living longer so that they can vote for them, and so that, that politicians fund what is visible. So I'm challenging the health economists to write to the politicians.
Thank you.
Yeah.
Bwana health economist.
Yeah, I'll put it like this. One is that I'm sure there are people who are not Kenyans here, but there are many Kenyans in the room. I want to know how many have led the follows. If you can just raise your hand. Led. You have led the follows. The follows that Dr. Newton talked about. Yes. You know where I come from, there is no R and L. Eh? So you might get confused. Very nice. So you see, it's 30% or 20. Now, I want to tell the African leaders, and more so those in country here, you cannot change what you don't know. You cannot influence politicians with what you have no idea about. So if you are not equipping yourself with the right information, with the right legal architecture, with the right understanding of what's being done, you have no basis to actually be able to correct it. And lastly, a rational human being in a market is supposed to observe two things. One is order your preference. So you know A is better than B. And as you order, what you put as A should be more important than what you put as B. Our politicians are very good in that rationality principle, just because our public always wants things to see. They see that hospital was built. They like it. So a politician will always place things that can be seen before what cannot be seen. So it is a work of all of us to also align. How do we make what is unseen become popular to respond to the politician's need, who is the population and the citizen?
Thank you, Dr. Moi. Dr. Wangia.
So for me, it's more of working very closely with the Ministry of Finance in this country, the National Treasury. And for us to do that, we need to know our priorities, know how much our priorities are, and for how long we need financing of those priorities. You can't finance something forever. So just working closely with the people who have the envelope.
Thank you. Elizabeth.
I think for me is for us to recognize that behind every financing discussion is a mother who's seeking care, or a child or a young person seeking prevention, or a community and family that is seeking dignity. And so truly all our financing discussions and choices should be aimed at honoring communities and families.
All right, thank you. So we are going to take 1 or 2 questions in the interest of time because it's up. Who will quickly shoot their question at the back? Maybe if you can give them a mic.
So before we do, I have a few comments from online. So we have Dr. Moy's point of optimizing the existing system other than expanding to different health levels without gap is very important. Thank you so much. He didn't mention his name. Secondly, getting money is key, but getting it right and efficiently with the resources is not just a health sector issue. It is a shared responsibility. Strategic intersectoral collaboration can reduce long-term costs and improve outcomes. Example, the Ministry of Agriculture can deploy technical experts to improve food security, which directly impacts nutrition-related health outcomes, hence reducing the burden of MOH. Also, the politics and Ministry of Trade should make doing business possible, including local manufacturing of drugs, technology integration, all the way to small-scale business functioning. Treasury ensuring efficiency through accountability. Thank you so much, Rose Wandia. For those who are asking questions, please make them short, precise, and to the point.
Thank you. Yeah, good morning, everyone. My name is Kenneth Ogendo. I work for Luala Community Alliance, and glad to have seen Professor Wafula and other great minds like Dr. Moa in the room. And my question to the panelists and the economists in the House, looking at the 4 laws that Dr. Moa has talked about, at least I know you in other circles, but today I'm coming in as a student. I'm a student of Strathmore doing a PhD and examining community health financing mechanisms. And like you rightly say, that we need to invest in prevention and promotion as a country. But if you study the 4 laws, the Financing Improvement Act, the Primary Healthcare Act, and the Social Health Insurance Act, we have either deliberately or inadvertently not specified how we shall finance prevention and promotion in this country. SHA can actually purchase services, strategic purchasing from level 4.3.2, but there is no provision for the strategic purchasing of level 1. Again, if you look at the FIF laws being made across the country, again, we are saying retain 100% of the money to the facility. And there's no money that is ring-fenced for financing community health services. And these are the things that happen at the house. Remember, all health decisions are made in the household. But we are not funding that area. And I like that that has come out from this panel. So my question is, what shall we do now that the law is already made? We have not yet ring-fenced or have had affirmative action for the services. How can we move the conversation forward? Of course, we appreciate the financing of community health workers, the stipends, but again, the stipends are not enough. We need to see how can we purchase the health services of a community health worker offering malaria prevention services, ANC, PNC. Would the economists under Social Health Authority, for example, cost some of those things and then enable the social health insurance now to purchase those services?
Thank
and
you.
Also FIF.
Thank you, Kennedy. Dr. Moi will take that question. Can we have the second question?
Thank you very much. My name is Dr. Charlotte Pahe from Population Services Kenya. I'm so happy to see many of my classmates up there. Dr. Anne, Dr. Elizabeth, every time we talk about these things, we fight a lot. At this point, I am not a believer in government-to-government funding. I have been in the NGO sector long enough to know that if you require someone to show you that they went to Marsabit, they will show you that they went even though they were in Nairobi the whole time. So the only hope that I think this country has is this resource mobilization that we are doing through SHA. And my question is actually directed at Dr. Moi, because I feel like for once, through this whole funding cuts, I've lost hope, but I feel like for once, if you're advising the president, I feel like we're okay. But I just wanted to know from you what this thing about, because it feels about like it's about maybe 11% of Kenyans that are paying into insurance. So in your expert opinion, what does it take for Kenya to have everybody contribute? Because it seems like if that resource base can expand, then we don't really have to panic about donor funding. And if we can actually effect what you've mentioned already. Thank you.
Thank you. Thank you, Dr. Sharon. We'll take the last question, please. At the back, he's had his hand up for a while.
Thank you. My name is Josephat Manani. My background is finance, and Orlando, I can say, is my classmate, examining costing in healthcare systems. My question goes to Dr. Mwai, and thank you very much for the insights you have been able to give us. My question is, if we look at sustainability, when we talk about how are we able to adapt, how is the healthcare system able to adapt to the changing world? I want to imagine that when you're advising government, how can we achieve a system where it's not left for any other government coming in to change things, so that we have a system that is almost autonomous, that those who practice in the healthcare system are able to channel their laws so that we are able to have a system where we know how much it costs to have a unit of a particular care. That is what we have to know. Currently, we can't know what costs for a particular, or to treat a particular ailment.
Thank you. Dr. Moy, I think all the questions are to you. But I'm going to ask Dr. Newton to handle the first one. Apologies, I hadn't notified you. So this is from Kenneth, and he wanted to know about the 4 laws. And how are we going to finance preventive and promotive services, even when we say that FIF, you know, the funds are available for health service delivery at the facility level. And then we'll have Dr. Moy take on the question from Sharon on the contribution, as well as from Josephat, which is closely related on cost units. Thank you.
Thank you for the question, and I've just seen my boss walking in, so I must be at my best. Yeah, so we have the 4 laws that were anchored in 2023, and the Primary Healthcare Act. I think what you have seen from all the narratives, if you look at the social media pages for the Ministry of Health and everything, the biggest priority for government is prevention more than treatment. So the Primary Health Care Act is actually supposed to take care of the prevention aspects for health. If you look at, I think the first question was also alluding to the fact that the community has been left out. There is no way of the community sharing this SHA cake. But I want also, I was also even consulting my colleague, Dr. Mwai here, that we have the social contracting framework that, and over and above the NGO framework, we have the Public Benefits Organizations Act. What does the Public Benefits Organizations Act design? What is it designed to do? I want to let you know that this Public PBO Act was first put forth 10 years ago. It was until this year when it has come to operation. The work of the Public Benefits Organizations Act is to make sure that the community is funded. If you look at the HIV world, for instance, one of the biggest drivers of the HIV scourge is the key populations. And there is no way they can be left out, even though they have been criminalized by the system. There is no way they can be left out in the response. Leaving them out in the response means that we'll get back to the numbers. The new infections for HIV will go back to where they used to be long time ago. So the Public Benefits Organizations Act is a law that is going to make the government have a way of funding the NGO sector so that the NGO sector can continue doing the work that they do that is contributing to the community benefits for health that we are seeing. So I think that is what I can say for question 1. Thank you.
Thank you. Dr. Moy?
Yeah, so I think those are 3 good questions, but I want to first address the community healthcare financing. And I want to say that it is also important for people to realize that there is no one single funding financing mechanism. SHA is a social insurance. Please remember there is government direct allocation. There is also voluntary, or what we call insurances that are private, among others. So as of now, the funding for community health is actually at the government allocation. That's where you find your stipend. The issue of the commodities, if you look at the architecture, they are linked to the link facilities. And that is where they should collect their commodities from, and those commodities are payable. So the social insurance is able to refund for the commodities that are dispensed for each of the facilities, including some of the commodities that are utilized by community health workers who are in their link facility. The architecture is still moving. The implementation rollout is not yet over. We are moving towards rolling out for commodities to make sure we are able to document and have accountability at that level. So I think that discussion will continue and may not end here, but there is a whole architecture on how to finance the community level system and how to have a robust referral system that brings people from community up to level 6 and sending them down back reversal, referral back to their place. Now, having said that, on the issue of the financing landscape, I think it's important for us to really be cognizant of the fact that there are a million costing studies that have been done on healthcare service delivery, including the activity-based costing for management that was done in 2022 that outlined the cost of services by level of care. The only problem is that, one, we never have where to store those analyses. Two, I think my laptop might have 70% of them. I mean, that's the reality. Now, that was a very primitive way of keeping data, so to speak, because if my laptop is stolen, of course, now I was told that there is a crowd, now I'm using crowd, but if it is stolen, or you cannot log into my crowd, I mean, you have really little information on to guide policy. So what I want to say is that we are moving towards institutionalization of activity-based costing. When you institutionalize, facilities are spending. As they spend, you can back end have little cost for healthcare services. The same way, we are moving towards the area of having a better way of tracking our resources so that as you spend, again, whether donor, private, public resources, it's possible to come back end and trace how did our resources get deployed and therefore attribute an outcome for the input, which is measured through the resources. So it's something that is going on, and I have seen our PS here. This PS is a person who loves prevention, so ask him about prevention. Those things you're asking me, ask him, he has come. You should be able to answer them. But having said that, we have a really robust architecture, and sometimes it's easy for people to just sit down somewhere because of ignorance or less of information, think that things are being done just for the sake of doing them. What I really want to encourage you this morning is that we are a very open population, and we don't believe in know-it-all. We want to hear from the people, technical people, not people just talking for the sake of talking, but technical people on areas that we need improvement, things that you think we should change. And if that happens, then we will map up our architecture in a way that all issues are addressed. Lastly, please read the report called The NHIF We Want. Now, when you read it, organize for a meeting. We tell you how is this government addressing each of those problems that were highlighted then that needed to be responded to. That is how systems move from one regime to the other. You pick up the learnings of the other regime, you address them. If you are not a politician, you need to be technical in the beginning. Then you address those critical issues as you move to the future.
Thank you.
But the last question was, how do we make it move across government? The health sector in Kenya have only operated through guidelines and something called ministry always give guidelines or what? Standards. So they give standards and guidelines. When followed, nobody cares, there is no else to go if it is not followed. How we have trying to architecture this to go beyond the regime that is there is to actually anchor these things in law. Because the law is of the land. The law does not belong to President William Ruto or the next one coming or the one that have gone. That's where we made a big mistake because we relied on things that can just be thrown out anyhow. And Kenya is a place where people know courts. So when you have a law, you can get accountability there. Thank you.
Thank you, Dr. Moi. Catch Dr. Moi at tea break for more information. Dr. Ann Musuva has a quick comment to make as we wrap up.
Yes, thank you, Chair. I just wanted to respond to Dr. Pahe's question about how we can make everybody contribute into SHA. Because right now the contribution is, I think, pretty low. I would say indirectly through taxes. Kenya has a population of, over 80% of Kenya's population is in the informal sector. So I think it's very ambitious to expect SHA or the Ministry of Health to outperform KRA in terms of collecting revenue for SHA and getting everyone to contribute into the Social Health Authority. So I know that is not a very popular stance, but I dare say that it needs to be indirect taxes into SHA.
Thank you. So that wraps up our panel. We have looked at how we got here. We've looked at the present. You know, what are the promising innovations that are promising to move us towards resilience, and what we need to do from here. So the conversation does not end here, it just starts, and hopefully the recommendations that we have had from here are now going to move to budget lines, to policies, to implementation plans, etc. Bwana PS, as you are coming in, I know you're a proponent of data. We were saying that we cannot divorce politics from funding decisions. And therefore, as we talk to the political class like yourselves, we need to have a way of packaging evidence to help, sorry, soon political class, not now. I beg your pardon. So we need to find a way of packaging that evidence so that we can equip the decision makers to enable us to have decisions that move us towards resilience. Thank you very much, our esteemed panels, and thank you, audience, for active participation. Back to you, Doreen, I think.
Yes, thank you. Thank you very much, all of you. I'll ask that you stay on the podium for just a quick minute. I'll also invite Dr. Gakombe to join us on the podium, and Professor Frank, so we don't want you to move out of the panel empty-handed. So we'll be giving you a few goodies. As that happens, I also want to quickly read out a comment that came out from this panel. And it says, good point by Kennedy, prevention and promotion could be financed by giving incentives to individuals who maintain good wellness scores, that's BMI, etc., just like in motor insurance, where motorists with fewer claims pay and a good driving record lowers premiums. That is from Dan Kula. So thank you very much for that observation. Prof, over to you to hand over the goodies to our panelists and also to our opening remark guest, Dr. Gakombe, as well.
Thank you.
I hope that has also given you one quick second to know your neighbor, to say hi, to see whether the messages are landing, you know. It's good to know your neighbor. We must expand our social capital, because if we don't, then again, as Dr. Moy said, we are not going to expand our social capital. All right, thank you very much, Rose, and to our first panelist members. Now, the number of times I've had the government being referenced this far is, and I've been keeping count, by the way. So it's, let me see where we are. Well, it's many times. And you all know why. It's because all these conversations, even as we are thinking about the impact of funding cuts, even as we are thinking of how we continue with our collaboration to make sure that we are bridging those funding gaps, whether it's from development partners, philanthropists, all that must be grounded within government structures. Dr. Kakombe did earlier allude to the governance issue, which mainly the government carries. And that is why even Dr. Moy has received very many questions once people figured out he's in the government structure. So now that we have our PS here, PS, we have been told by Dr. Moy, we must rally more of the government officials, but also the politicians. So we are hoping you're going to do that for us, because we've been told we have very many people in the health sector here, but we need that other part, the government and the politicians. So allow me then, ladies and gentlemen, to invite our PS, Dr. Uma Luga, Principal Secretary, State Department of Medical Services in the Ministry of Health, who is going to talk to us about leadership in transition and what we are doing in terms of reforms. Welcome, PS.
Thank you so much for enabling me to be here. I can see a number of colleagues in the audience. Thank you, Prof. Frank, and our good teams. You know, when Mwai has already been in the panel, I am almost struggling to know what he told you so that we are not off script. But I think what is important is that, that I'm here and that I want to align myself with the case for sustainable health financing because it's a topic that I love to speak about. Although you told me to talk about leadership in transition, I don't know what leadership in transition is. Because, you know, leadership is what you do when you're there. So there's never been leadership in transition. In this phase where we are discussing money that is meant for health, leadership plays a very key role. And you cannot look at it from a transient or from a time-bound perspective. We have to anchor it. We have to anchor it at the center of sustaining the financing mechanisms. So I know that a lot has already been said about donors and what they were funding and whether they were aligned with the government and how much money, which we don't know. I think, I'm sure you guys have already talked about the visibility of donor money, which, and sometimes, let me say, donor willingness to even show us their money, you know, and for those of us that speak straight, we've had a few run-ins with some people because they come to the office, they want to tell you that they are supporting you, you agree that they are supporting you, but then you don't know what they are supporting. So they tell you, no, I'll support you to do this, but tell, okay, so how much money are you putting in? Who are you putting in? Who are you financing to do it? And so I think there is also a lot of gray areas there. Lastly, of course, is the donor reporting, because some of the people who implement donor projects also have a channel of who gave them the money and what those people require them to do. And I think there's been a lot of conflicts there. So I don't think I'll talk much about that. What I wanted to talk about is really right now how we are looking at healthcare financing. And I'll give us a very simple analogy of what healthcare financing means for us in the government. And I know that Mwai must have done this, because I don't know if he can ever talk about anything without talking about it. But the whole healthcare system, the whole healthcare as an agenda is being looked at from an economic perspective. I think that's the first shift in mindset that we must have. And it's a big deal to look at health from an economic perspective. And health from an economic perspective is not necessarily how to finance health. It's about what health means in the overall transformative agenda for the country. Yeah, I think that's where really the leadership is. What does healthcare mean for us in terms of transforming our economy to where we want it to be? What does it mean? And I think that's where the gist of all of this discussion is. And that's why health is one of the 5 bottom-up economic transformation agenda that we have. The other 4 is housing and settlement, enterprise, that is through the MSMEs, issues around digitization and creative economy, and then of course food security and agriculture. So if we appreciate why health is being used to drive economic transformation, then we can now talk about the leadership. Because many people look at health from a service delivery, social rights issue, which is okay, and that's exactly what it is. But then they don't appreciate the input of health in driving countries in terms of healthy populations being able to be productive, but more importantly in terms of lost man hours. And just 2 issues around there. For example, forget about the money that we put in health. Look at the opportunity costs of bad health. And the opportunity costs of bad health in our country today, we spend 700 billion shillings in education, that we have to finance schools, we have to finance bursaries. Do you know why? Because our people are not healthy enough to be productive. We have a lot of orphaned children, people who their parents died and they can no longer be supported through the school system. So look at the things, the opportunity costs first, and it's huge. And that's the economic imperative for health. On this other side, look at the big disease baskets. And if you look at the big disease baskets, something, for example, like dialysis, and the amount of money that we spend just doing dialysis, around 7 billion. And how all of these people, they go into the system, they are kept alive, but they are not kept healthy enough to be productive. That's another economic issue. So you spend 7 billion shillings doing dialysis, but all the 7,000 or so patients that are there, they're just getting by because their blood levels are not good enough for them to be in the offices working. You know, so they go to the hospital, they get dialysis, they go back home, then they rest for 2 days, just enough to go back for another dialysis. And this is the life of many of them. So if you look at health as an economic imperative, then you see first the opportunity cost, but also the actions within healthcare, what it means for health, not what it means just to treat people. So once we've looked at that, now we can talk about financing, because those two issues are the key driving forces of how we look at financing. And that's part of the difficulty, that we face in terms of this transition right now from the old system of financing healthcare and the new one. And I think Mwai must have talked about this better than I did. Yeah? I think he must have talked about that economic imperative. It's really the agenda. And that's where the leadership comes in, because we have to frame what financing means for health before we frame how to finance health. We have to frame what it means for health before you just throw money at the things that are there in health. And so within the health ecosystem or the agenda, and looking at it from this lens of economic transformation, there are now 4 key priority areas. One of them is this whole issue about domestic resource mobilization, which ties in with our resilience, transitions, and all of these things. And I think that answers the question about sustainability, because sustainability means that you are at the driving seat of what you do. But you can't be at the driving seat of what you do if the money is not yours. So I know we're going to talk about donors and the transition and all of that. But for us, we are almost stupid at it. Stupid at it in the sense that for a moment I have to stop discussing your money, because there's no way, if I stick to discussing how I want to move from your money to my money, I will always get stuck there. So I have to be extremely clear that what we need is our domestic resources. End of story. True or false? Yeah? And that's why domestic resource mobilization is a do or die for the government. And I have to say it that way. So wherever you go, this is it. I have had the privilege of meeting with the national, the Network for Persons Living with HIV, NEFAC, and all of these patient groups, including our diabetic groups. And I really love going into those spaces. And often they tell me, oh, you know, we want this in the SHAB package, or, you know, the donors are going, so how is this going to be? My response is, tell me how we are going to mobilize our domestic resources. So this room today, for you to answer sustainability, the answer you need to leave this room with is how all of you are going to mobilize domestic resources. So everything else you've discussed, I don't know what exactly you discussed, but that's it. If you don't discuss that one, then end of discussion. How we will mobilize our own domestic resources so that we stop getting annoyed, we stop planning, we stop thinking that somebody else is going to give us their money and ours is to use it. However efficient you want to pretend, you can plan how to use it. And that's the end of leadership in transition. You mobilize your own resources, you don't cry about somebody else's money. And that is why the issue about the social health authority for us is important. Now, how do you mobilize resources domestically? Somebody, and Musumba mentioned it, about the taxes versus contributions. And we are doing both. So we have two mechanisms. One is, of course, tax contributions, and then self-contributions. There can be a lot of arguments about tax contributions versus and which one you need to do and all of that. All of these things are still economic factors. There are a lot of economic factors, and I'll tell you two. One is that we are still a developing country that are just coming out of a debt distress. So there are a lot of factors that play in how you collect your taxes, including some of the big brothers, the IMFs. Okay? So there are some ceilings that also determine how you collect your taxes and what taxes you collect. That's one of them, that economic play of the country's position, which we have moved in very well. I think the president says this story more than I do, when many countries were expected to default. And he said it before, and Kenya didn't. And now we've even moved ahead in terms of how big our economy is, from number 8 to number 6 in terms of Africa. But sometimes if you are in a land of the blind and you have one eye, and so Kenya is that country that is in the land of the blind, but we have one eye. But we have to appreciate our one eye. So that's a big issue that we may not come and tell you here about, can you put in taxes, can you expand this? But the second bit about this is about the people. What do the people want to pay for? And number two, can they? You've also seen the challenges that came with the Finance Bill 2024, right? So the more you push people, you can tell people today that if you are employed, we'll take 15% of your tax. That's what you are saying. And put it to health. Okay? So you look at the tax bracket and you look at who exactly pays tax. How much more can I push them to pay? I hope you understand what I'm saying. So it's not a simple answer. So there is the interplay at that level, and then there is the interplay with the people. Can they afford it or not? And so looking at all those factors, the government is very clear about leading a dichotomy or a two-pronged approach in terms of mobilizing resources here. One is taxes, so that we can accommodate the whole issue about what people pay for, how you can utilize it to still do defense, water. I've talked to you about education, and all of these things, and still finance healthcare. And then there is a mechanism that may not get into the tax bracket, but you still give people to participate in financing their own healthcare through contributions. And that is why, under the Social Health Authority, we have the Primary Healthcare Fund, the Emergency Chronic Critical Illness Fund. Those two are tax funded. And I think it is the first time in this country, and I think it's also the first time in many places in Africa, that a government is directly putting in tax funding to healthcare. The question is, because it is tax, what exactly do you put it for? And if you look at the composite or the services that are being paid for with the Primary Healthcare Fund, they are the basic services that fall on the fundamental package that every citizen has a right to access. That's the primary healthcare services that are being funded through the primary healthcare fund, level 2 and level 3. So this is very bold in terms of putting tax to finance things that every citizen, just by being Kenyan, you are entitled to. And then there are other services that, irrespective of how much money you have, irrespective of whether you have a good job or a bad job, you have little determination of how your care can be organized. For example, it doesn't matter whether you have the best gold card here for insurance. If you got an emergency, by the time people determine who you are and whether you have a gold card or not, they have thrown you somewhere. Yeah? And so those are the things that are being covered again. The fundamental things that whether you are poor, whether you are rich, whether you are educated, whether you are not educated, you are a human being, and the government insists this one must be taken care of. So the emergency, chronic, critical illnesses, the issues around ICU, I've mentioned for you chronic diseases. And sometimes also things like, and I like using the dialysis and cancer, that if they are not paid for, you either will get poor and again get into that economic burden, or you will die. For example, many of us here who are employed and we have some small salary, if you were to pay 1.1 million shillings a year for dialysis, you will get poor. And even if you were to sell your land, you can't sustain it. So the first year you can sell land, sell a house, sell cows, but how long can you do that as an individual? You can't. And the other thing is that it also takes away money that then you would use to build the economy. You would use to pay school fee for your children. So when it goes to the overall narrative of health as an economic issue. So these are the things that are being covered. Cancer, for example. We have 5 common cancers in this country. Yeah, we have, the highest burden cancers: cervical cancer, breast cancer, prostate, colorectal cancer, and esophageal cancer. That's the solid tumor side. Most of them, find somebody needs a surgery, they need radiotherapy here, they need chemotherapy here. Averagely, you'd get done with around 600,000 to 1 million shillings. If you look at the places where these cases come from, people have small pieces of land, some cows. If you subject them to paying that, within 4 months, they don't have anything else that they own. Now, if you look at esophageal cancer, for example, so you subject people to doing that, but we also know that the average survival in this country is 11 months. So you can imagine how people can drain all their resources meant to pay school fee for children, doing that. So those are the things that government thinks are very important because it keeps people economically viable. It's very important to understand these things. And those are the things that go to the tax funding. But there are other things that we want everyone to participate in. You know, you have maybe a bad knee here and there. It's been getting worse over the years. It will take about 10 years to get worse. You can be sorted. You go to a doctor. You may not have immediate money to pay the consultation, but you can call Dr. Luga. You're not going to die today. It may not stop you from going to the office because you can take Panadol and still work for two more months, managing the pain. So we want people to participate in paying for these things. These are the things that we have lumped in what we call the Social Health Insurance Fund. And also looking at, again, the interplay of who can pay and who can't pay. There's about 20% of Kenyans who are employed. So those ones are easy. Your employer becomes an agent. If they are diligent enough to work with us and to obey the law, then it's not a big deal. We have the 2.75% they contribute in. Now, there's another 40% who are not in that space of employed people. These are the people who They have some goats somewhere in Kajiado. Every year, within 3 months of the 12 months, they sell goats. They may make some money, 40,000, 200,000. Sometimes they make more money than you, you know. Some guy who is doing boda, he can make some 1,500 shillings at the end of the day. The market woman, one day she gets good sales, you know. She has sold her tomatoes. There's some income somewhere. And we want people to participate. And so this is the group that we really have to discuss here. How do we get them to pay for their health care? That's around 40% of the society. And they are there, and you know them. They run shops, hardwares. Yeah, they are pretty, they are struggling just the same as the guy who is employed. It's not that the guy who is employed has so much money. And we need the whole country to have this mindset shift. That is the other assignment that you need to come out with here. How do we get, and it's more of a mindset rather than money. Because the money is there. The money is there. You find them somewhere in the bus. They contribute. They are the ones in the villages contributing 1 million and 2 million. They are the ones in the chamas. So it's more of how do we shape our mindsets as a country to determine the social health authority as our collective Arambe. That this is the Arambe of the country. Because if we don't get that right, everything we are discussing about domestic resource mobilization doesn't go right. And by extension, the sustainable health financing. I wanted to make it very basic. I know you guys are professors, you're good, and I pray I get there. But I hope that I've talked in layperson's language, because that is the big deal about sustaining our health financing. Now, there are only 2 other things I want to say about the transition. One is that we need to know what to transit. Okay? We need to know what to transit. Of course, there are the things that so far we have what we call the health benefit package. So in this health benefit package, what is very important is to know what exactly is important for health that is not covered for. Whatever is not covered for, was it being covered for by somebody else? Okay? Now, if this somebody else has completely left or they are planning to leave, how then do they play in this space? And the play for me is that they have to align with what we are doing. Because I've already mentioned, we don't want to cry about somebody else's money. So there is no discussion about that. So there is no discussion about what you want to do. No. So you can only help us by telling us that you have this 20% of people who you're taking money from their salaries, you have this 40% who can go by. We have this other pool of people who won't pay, can't pay, because they have not yet gotten into that economic capability to pay. We have around 4.3 million of them, the group that the president has also launched a sponsorship program. So, how do we sponsor these people? That's one. Number 2 is that if there are some specific services, HIV, TB, malaria, family planning, that were still not included, can you put that money in our health financing mechanism? And the law allows it, donation, grants. That's how we get to sustainable health financing. So that we know that we have 2,000 shillings, we have this range of services that we want to provide, and then we can sit in our room and decide that this service is important, this one we can wait, this one is causing a lot of economic problems in the country, you know, giving us a lot of orphans, this one is making people not to be, to lose work hours. Because I've mentioned for you what we look at when we decide on health financing. So that, for me, is the frame with which we need to have this discussion. But the last bit which is the last thing I want to talk about, is what I found my colleague Dr. Mwai talking about. Institutionalization of partner engagement, institutionalization of how money comes into the healthcare system. We have had several discussions, and at the level of development organizations under the office of the Deputy President, they are keen to drive the one plan, one M&E, one budget agenda. At our level, we have established a health policy platform, and we are looking at the health side, that is the epidemiological issues on the health side, but then there is also the economic issues, and we want to marry the two. But how to marry the two is to create an opportunity for people to participate and to create a criteria and a structure that then enables us to see how money enters the healthcare system, what it does, and the outcomes, so that we can tell you that the money you gave in that corner of Turkana to finance trachoma did not achieve the results that you wanted. Of course, there's digitization in there. But we are very keen to strengthen this platform. And then it becomes the only opening through which partners and friends who still want to be with us can participate in the healthcare system. And we develop this criteria, and I know Mwai may have discussed it a bit. And that's how we are thinking about the donor transition. That first of all, we need to know, what were you doing? Some we do, some we don't. But more importantly, moving forward, that if you want to engage with us, there is an entry and an exit. That entry and an exit moves through a pipe. That pipe is what the government wants. We call it alignment. So that it has to align with how we think about our sustainability. And I've already mentioned how we think about our sustainability is to have our own money. So if you're going to give us money, you make that money ours. Then we decide how the healthcare system moves. With those very many remarks, I want to plead with you to help us on this assignment. When we live here, how do we get our own money for health? That is the question, and it is not as much a political question as people think. It is a very personal question, because you can't cry about my money. If today I refuse to buy for you tea in a hotel, there's nothing you can do about it, however much you discuss. Thank you.
Thank you, PS. PS, may I ask that you stay on the podium for a photo, but also, here, Frank. For a photo, but also for Frank to be able to gift you. As we do that, I want us to prepare for our coffee and wellness break, as Prof is gifting our PS, but also ask any speaker that is going to speak today and any moderator that is here, please come to the podium. We want to have a picture as we allow the rest of the teams to just step out for coffee. Because we are very short of time, I'll ask that we have our coffee and wellness break within 10 minutes and be back here by 12:05. Is that a fair proposal? Sounds fair. So let's be back here in the room at 12:05. So we can continue with our fireside chat and the next panel. But for now, please, all the speakers and the moderators, please come to the front. Then we can all have that group picture. Thank you very much. All our speakers for today and moderators, please come to the front.
Noel.
Our photographers, please tell us whether we are lined up nicely. Thank you, speakers. Thank you very much. Our dear speakers, we now invite you for our tea break. Please feel free.
Please, let's proceed outside for tea, kindly. Those who are still inside, let's proceed outside for tea, kindly. For online audience, we'll be coming back at 12:05.
Mic check 1 2. Mic check. 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 Mic check.
test 1, 2, 3. Mic test 1, 2, 3. Test 1.
Mic check, 1, 2. Mic check, mic check. Mic check. Check, mic check.
All right, welcome back from the wellness break. Shall we kindly settle down so we begin the next program for our day today? Kindly, shall we settle down so we begin our program? So I know you have a program in front of you. If you did scan the QR code to get our program for today, we want to make a quick change because our time has sort of run by pretty fast. So we want to make a quick adjustment where we were to come back and have a fireside chat where we would hear the unbowed stories of resilience when we are looking at the impact of funding cuts, but also what people are doing on the ground as resilience. But we want to shift that and go to panel 2, our panel 2 session, and then we are going to have the fireside chat after our lunch break. I know, and I'm still waiting for people to come in before I invite the next panel. I'm still waiting for more people to walk into the hall, including some of the speakers. But I think what we have heard so far, because I did promise today we are going to put a face to the stories that we are talking about on funding cuts. And I think we've been able to do that. Our PES did ground us on how health is a driver for economic transformation. So it's looking at funding cuts in a holistic manner. He did also mention when we think about health, whether we are thinking about healthy populations, the productivity of our people, whether we are thinking about the cost of bad health. Very, very important. And all the lost manpower time that we lose due to bad health. So we've had a whole lot of the domino effect of poor health and poor healthcare systems. And now we want to see what that means. And panel 2 is going to help us do that. So allow me then to invite panel 2 members, starting with the moderator for that panel session, where we'll be talking about the new realities, how health systems are adjusting to and coping with reduced aid. Dr. Noel Orata, from Strathmore Business School, Ecosystem Design Lead, and from the Open Fences is going to moderate this particular session for us. And I want to invite the panelists as well to join us on the floor. I will begin with Alice Kangede, the Chief Executive Officer of Beginnings Fund, Dr. Tim Deuri, the Chief Executive Officer of the Kenya Health Federation, Dr. Chris Barasa, the General Secretary and Chief Executive Officer of the Christian Health Association of Kenya. Please join us on the podium. Dr. Anita Msienga, the health economist and policy expert at Kemri Wellcome Trust. Apologies. Douglas Bosire, the acting CEO of the National Syndemic Disease Control Council. Kindly join us on the podium as well. And Dr. Matiko Riro, health economist and chief executive officer of Savannah Global Health Institute. Thank you for having us all here. Welcome. Dr. Noel, over to you.
Thank you, Doreen. So I just want to pick up from where the PS left off, that healthcare is complex, it's intricate, it's interconnected, and we need to integrate it. And it's an economic imperative that we're able to articulate to those who make laws to be able to facilitate our healthcare agenda in the country. My session is Resilience in Transition, the case for sustainable health financing and Africa's way forward. And we'll be looking at, so we've discussed about where we've been, where we are, and now want to begin to have a conversation about how do we want to go forward. And we're looking at what are the new realities? How are health systems going to adjust to these changes and cope with reduced funding? I think healthcare is one of those sectors that intersects with everything. Myself, I'm a consultant pathologist doing a lot of lab work, and I'm probably the only person who goes to the justice system by virtue of my job. And this is how intricate healthcare is. But I cannot do that to support a gender-based violence victim who may have died if there's no way we can finance that for her. And so we want to have this conversation. I'm going to quickly jump into the questions coming from what Oluga said. And I want to start by asking Dr. Anita at the end about health policies in this country. I think there's been, historically, we've had a lot of fantastic policies, perhaps created with certain organizations and agendas being pushed. But I am so proud of Kenya at the moment that we're taking charge of our healthcare. This is in the fringe lines of the 4 laws that have been implemented, and quality of care is also there doing push-ups, just about to come in. So I think we'll have 5. And I wanted to ask you, so Dr. Anita Musiega is a health economist and policy expert at Kemri Wellcome Trust. And I wanted to ask you, to what extent do you think Kenya's national health policies, especially those around health financing, how are they grounded in accurate, timely, and context-specific data, and where are the gaps that risk undermining effective policy implementation?
Thanks, Dr. Noel, for the opportunity and for all of you for being here today. Should I just start by saying that our policies are driven by interests? Kenya as a country is led by interests. So in my opinion, data comes at a second after we've looked at interests, what are people's interests. So at the beginning of SHA, the government and other policy, and that's the FIF law, the SHA, the Digital Health Act, and the now soon to be Quality Healthcare Act, the Primary Healthcare Act. Academics, the Ministry of Health, policymakers, everyone sat down to come up with the SHA regulations, to come up with the benefit package. Initially, when the SHA law was instituted, the figure that was in mind, people thought that it would cost us about 150 billion to finance SHA. Shock to them, after that process, we needed 450 billion, which we did not have. They optimized it to 250 billion, optimized it again to 150 billion. But I don't blame them. Like when the laws were coming in place, I think the government got the wrong agenda that these laws are going to be budget neutral. Were they budget neutral? No. But where should the policymakers, or where would they have gotten the data? We have data quality issues, we have data availability issues, our data systems are donor dependent, and I'm glad that the government actually acknowledged this and set up, besides all these laws, a digital health agency that is ideally supposed to support with coming up with the data. So were our policies data-driven? I would say no. Which data? It's not available. Whatever is available is not quality data. So I think, but I'm glad the government is working towards that. As they continue collecting data, then they are continuing to optimize their social health acts, their facility improvement financing acts to improve. But given the extent of data we had, in my opinion, they tried and they kept trying, because like the FIF Act, it was informed by the information and data collected by our good friends like Nakuru County Government. I have seen Dr. Joy here. So there was a bit of data on what Nakuru has done, but as Africans, we need to do better at recording what we see, keeping our data accurate, quality data available, so that we are able then to make the right decisions. Thank you, Noel.
Thank you, Anita. So they say in Africa, stories were passed on, through voice, and our grandfathers and grandmothers told us stories. So maybe it's a historical thing that we struggle with. And I want to go straight to Dr. Matiko to tell us more about how we can now aggregate the data that we ideally should be collecting. And in the context of shrinking donor budgets, How can Africa health system strategically leverage digital health innovations and private sector technology solutions to reduce duplication? I think as a pathologist, I am not a proponent of vertical programs. And maybe just a quick one. You would find that we have fantastic lab technicians who are great at diagnosing malaria, but the same patient goes into kidney failure and they don't know what to do for those tests. So I'm very happy about the integration, and I think we'll get to that. But how is it that, how can we leverage digital health innovations and private sector technology solutions to reduce duplication, improve efficiency, and maintain quality of care without escalating costs?
Good, thanks, Noel. I think I'll use to describe this just some work that we're currently doing at Savannah Global Health Institute with the government, with funding from the Gates Foundation in driving what you're calling DPI, Digital Public Infrastructure for Health Planning. So what we're looking at it, so the outlook is there are funds flowing and they're fragmented. So there are multiple funds. By the time healthcare is being provided at the health facility, there are probably over 10 funding streams that go. So I want you to imagine in our setting currently, SHA is going to the facilities. There are, of course, equitable share allocations that all the way ends up to the facility level. There are different donors, of course, sending all the way to the facility level. It could be funds from the World Bank and others. So there's a lot of duplication along the way, but the interesting thing is, once it gets to the facility itself, and of course, there are a lot of inefficiencies, as you can imagine, somehow crowding out others or leading out to maybe other budgets being crowded out to be allocated in other places. It leads to healthcare being provided. This healthcare provision is being recorded through the KHIS and others. So what we are doing at Savannah is, let's look at all these data flows. Can we at least improve visibility of funding flows by first improving interoperability and creating a platform? So one of the outputs that we're looking at, can we create a platform that improves visibility? Because we believe visibility is a driver of accountability, and the other result that we could get is actually efficiencies in terms of allocation of resources. So we're trying to look at money goes in and it buys out health services, which is reported on many other platforms, but then we are going to work out something we're calling value for money. So how are we getting the data that is being generated from the health services being provided, and actually enable even donors be able to see, did we get the money that was given to buy a given commodity, did it actually get there? If there is money that went on to, let's say, to target population, let's say teenage mothers, are we able to see that it actually reached there? So a digital platform that enables us to reach there, that's what we're looking at. And so the key element then we're looking at, Noel, is a digital public infrastructure that is embraced by both the government and donors, especially in the reporting perspectives in terms of how the money is flowing, but also even when you're looking at what we've traditionally done, and I think Dr. Luga alluded to it, on donor resource mapping and reporting, but also what the aspiration of the ministry is on one report, one plan, one budget, one M&E, because what has continuously happened, and I think, from my experience in a number of countries that we've supported, a country like Malawi ends up having about over 50 strategic plans, and once you have that number of plans, I want you to imagine, and I know my friend Newton was here, he's worked in NASCOP and a couple of other programs for long. When you're doing a TB program strategic plan, it sort of imagines that TB is being provided in isolation. So even the budgeting you're doing for health workers, it's basically around the health workers for TB, ignoring that the same health worker is the one that provides antihypertensives, the same one that does ANC, and the same one that does other services. And so what we're looking to getting is a more interoperable system of data systems that can enable at some point to get to that aspiration of one plan, one budget, one M&E. And for us, we see that as a driver to getting more accountability and efficiency, and especially even with the donors that are still in the table, because I know that not many, even as we say, yeah, let's drive more domestic resources, but also there are ways in which we can still continue working with other partners. But even domestically, it makes sense if we're actually accountable to the fact that there is money flowing, but there are health services that we're getting back. And we're trying to achieve this together with the partnership with the government by building a stronger digital public infrastructure that can enable us to see how much value of money are we creating. Thanks.
Thank you. So I started with Anita from policy level, and then I went into integration. And now I want to have a question for Alice, who's the CEO of Beginnings Fund. Many agree that the era as we know it is gone. So things have definitely changed, geopolitics, geofinancing, and these adjustments. So with donor aid shrinking, how is the Beginnings Fund leveraging local philanthropy and domestic capital to sustain health programs, especially around serving the vulnerable populations, and what incentives or structures are proving most effective?
Thank you for having me and gathering this group of people here as we think about sustaining financing for health. The Beginnings Fund, for those who don't know, is a relatively new philanthropic initiative that is pulling philanthropic funding to address maternal and newborn health in 10 countries on the continent, and Kenya is one of those countries. And you're right, the days of aid as we know it are gone. And I was very happy to hear the PS, Oluga, articulate that over and over again, that I think we need to stop mourning and actually think about what does the world look like beyond this season. So Beginnings Fund is bringing in philanthropic capital, and it actually pulls philanthropic capital from the global south. So there's Delta Philanthropies is one of the anchor funders. This is the Masiyiwa family from Zimbabwe who also run Econet Wireless. Capital from the Middle East, the Mohammed bin Zayed Foundation for Humanity, the president of the UAE, and also philanthropic capital from the global north. Gates Foundation, Elmer Philanthropies, and the Children's Investment Fund Foundation are part of the anchor funders. What is different, I think, is what should have been, but now we have to live true to the value, is planning with government. As Dr. Oluga said it, we are very intentional about creating what the investment will be with government. The chief of health services in Malawi said something very powerful to me, one of the priority countries. She said, Dr. Chunda, we are Malawian, we know this country, we know our population, we have provided care as senior technical leaders, but donors come to our country, they pretend to know Malawi more than we do. They will come and shake hands and take pictures. So everybody says they work with government. That includes it. You shake hands and you take a photo. And then after that, people are running all over the country, implementing programs, but not really led by the government, not really owned by the government. And unfortunately, sometimes we then bring those programs back and say, now we want the government to take them on. And she said, so we treat governments like morticians. We are bringing the patient at the end of the journey and saying, now we want you to, literally resuscitate this program. So what needs to be different, and the approach that the Beginnings Fund is saying is, we co-create, we co-design the investment with the government, thinking about sustainability from the outset. I'll give you an example. One of the core pillars is health workforce for maternal and newborn care. Beginnings Fund is willing to support not just upskilling, but also hiring new health workers. So what that number would look like, which cadres will be supported, which counties will be prioritized, is something that we agree upon with the government. Some governments have actually said our need is larger. One of the governments said, we need approximately 1,500 midwives, but we will only put 1,200 in this plan because that's what we can physically commit to absorbing within our budgets. And that then means that that investment will outlive the fund. So I would say for any funders who are still at the table, what we really need to do differently, and what this opportunity for me of the funding cuts creates, is to truly partner with government, to truly have the government on the driving seat, and to think about the sustainability from the outset. So as Dr. Oluga said, we are supporting the government plan. We are not supporting or funding a Beginnings Fund plan, so to say. Thank you.
Thank you so much, Alice. And I think that's very, very important. I think, you know, so to speak, a lot of things were dictated without the people who know the true needs contributing towards that conversation. And I love that Beginnings Fund is beginning to realize that people know what they want. If you ask them, they'll tell you. And now I want to segue into Douglas Bosire, the acting CEO of the National Syndemic Disease Control Council, which for me as a pathologist is the best thing since fresh bread, because they have begun to integrate their programs. And I wanted to ask you, how is the public health sector adapting to the constraints in funding? And what are the trade-offs being made between national priorities and health needs on the ground in the face of reducing funding?
Thank you very much, Dr. Noel. First of all, I'd just like to take this opportunity to thank the organizers of this forum for having us this morning or this afternoon. It is indeed a very contemporary discussion, particularly when we see where we are as a country in terms of the health sector. When the executive order number 14169 was issued by the US government on the 20th of January this year, it got us all worried. NSDCC, for those who don't know, is the successor of the National AIDS Control Council, and we were formed in the year 2022. Africa-wise, we have an organization, actually globally, we have an organization for the AIDS Control Councils that are leading the responses in their various countries. And all of us were shocked. Not shocked with the, not knowing that this will come. We knew that it will come, but we did not know that it will come that fast and that rapid. I can say, you know, depending on how you look at it, it can be, there's some silver lining in this dark cloud that hit us. There was a lot of anxiety, TB, HIV, malaria commodities, nutrition, blood and blood products, oxygen. All these, you know, aspects were interrupted in a way, including our data systems. However, for us as a country, Dr. Noel, we had foreseen this. Actually, back in 2022, we had already drawn a roadmap for transitioning the financing of the HIV response in the country, which was the worst affected, which was most affected by these stop work orders. You know, so we had developed this framework. And last year, during the World AIDS Day on 1st of December, 2024, we actually launched the Kenya Operational Plan towards readiness for the country to sustain the HIV response to 2030 and beyond. 2030 being the target that we have given ourselves globally. And if we listen to what the PS was talking about, first of all was the aspect of leadership and accountability. And you can see what's happening at the national level. Leadership is at the core that we need to commit to account for the poor affected or infected with HIV and other syndemic diseases. And that is why it is imperative that these common mobilities are integrated within the financing mechanism that we have come up with, and therefore the urge and the response that we are currently having in terms of identifying which particular packages get into the essential package that then will ensure sustainability from a financial perspective. We have about 47, we have of course 47 counties, and these 47 counties also implement. That's where they implement activities. So the first thing also that happened in the counties with this shock, remember you would go to a public facility, there's a comprehensive care clinic, there's an outpatient clinic, somebody for malaria treated at the outpatient clinic, there's a TB center there, there's a comprehensive care clinic for HIV. The clinician who's working at the CCC has never been to the OPD. The one working at the OPD hired by the county has never been to the CCC, to the comprehensive care clinic for HIV. And then these people are paid. Whether the money is coming from donors, whether the money is coming from Kenyans, it's money that is meant for Kenyans. So the integration process also started, so that we have integrated service delivery. Let us put, if the CCC is the most comprehensive place where we can move OPD services, let's move OPD services to the CCC. If otherwise, let's move the CCCs to the OPD. And I can say without any doubt that a majority, almost 70-something% of the facilities in the country right now have actually integrated their services. That notwithstanding the fact that there are challenges. There are challenges in that integration process, and therefore, this, you know, the issue of the trade-offs that Dr. Noel has alluded to, which I'll mention in a second. And then, of course, the issue of efficient health products and technologies management. We had a problem when this order came, because the US commodities are supplied through Mission for Essential Drug Supplies, MEDS. The Global Fund supported commodities for malaria, TB, and HIV are the GOK supported commodities are distributed through the Kenya Medical Supplies Authority. Now, the nevirapine, which is very important for prevention of mother to child, all the stocks were at MEDS. And that is where you might have had you and cry about stockouts. It was a challenge actually of nevirapine, because the stop work order, there are stocks that were in the stores at MEDS in Mombasa Road, but these stocks cannot be released because the distribution work has been stopped. They don't have resources to send their trucks out. So we also realize that these two agencies must talk together. At any one time, we must know what's going on at MEDS. At one time, we must know what's going on at KEMSA and what they have. And now we have the visibility of that so that we can do a prediction. How many months of stock do we have? Is it 3, 4, 5 months? And for the critical tracer commodities, how many months do we need? And therefore, we need government intervention. And the government actually intervened. And right now, we have a stability in the supply chain system. And I think Newton in the morning alluded to that. So there's been a lot that has happened. Of course, there are trade-offs. There is the issue of the prevention program being highly affected, particularly for the high-risk populations, that people we call key populations. There are populations like men who have sex with men, female sex workers, and the prevalence for HIV, by the way, is much higher than the normal. Female sex workers have a prevalence which is almost 10 times higher than the normal population. Men who have sex with men have a prevalence which is almost 6 times higher than the normal population. People who inject drugs have a prevalence of about almost 3 times higher than the normal population. And these are a particular cohort of the population that if we do not address the new infections amongst them, then they can end up enhancing the infections and the prevalence among the general population. So that was affected because, for example, for the prevention program under the USG, it was that it has to only deal with mothers who are either pregnant or mothers who are breastfeeding. So the counties have also integrated those programs. We have said, if you have a KP program, a program, for example, for men who have sex with men, which is a standalone facility, do not only call that a men who have sex with men dies, drop-in center. Open it to the general public because you have a clinician there. These people can be able to deal with common morbidities. They can be able to deal with a client who has diabetes, who has malaria, who has hypertension. So open it. And in the process, in the negotiation that now we are having with the US government for the multi-year financing mechanism, which is bilateral between Kenya and the US, we are also looking at how these facilities can be integrated in the true sense and not be standalone. Of course, the issue of stigma, people will feel that they have been stigmatized when they are sent to the OPD, but through on-the-job training, through regular interaction with the health workers, that is coming down. So, Dr. Noel, I can say without fear of contradiction that Kenya is one of the countries actually that is leading this response of transitioning. It is something that we should have, a discussion that we should have had 10 years ago, but sometimes God's timing is the best timing. So this is the time that we have, and we have to make a mark when we're here. Thank you.
Thank you, Douglas. I absolutely agree. And now I want to move to Dr. Tim Theory, seated on my right, the Chief Executive Officer of the Kenya Healthcare Federation. And now I want to move into practice and how these constraints has affected practice from a macroscopic level, and then we'll move to facility level. So, Dr. Theory, what lessons from the private sector can be drawn from public sector adoption in a resource-constrained environment, and what strategic shifts in the private health sector is the private health sector making to position itself, not just as a service provider, but as a co-investor with government in building health system resilience?
You've asked a question that is long, so I can answer the one that is in my mind. Thank you, Noel. My name is Dr. Theory, as you've been told, from KHF. Our work is very simple. We optimize the relationship between the person who's taking care and where they get it from. And one such attempt is engagements like this. But more importantly, these conversations cannot remain here. They must leave the room. And the reason I say that is because and we discuss this often with Chris here on my left, we attend so many meetings of this nature, and the next one tends to be the same one, like the one you left. And I think how I can distill it out of attending those meetings is, and I'd like to draw a social parallel, and that is, as a man, when you are luring someone, preferably a female with a promise for a better life, you must have a plan, isn't it? Isn't it? You must have a plan. Perhaps a plan that when you come together, Safaricom says great things may happen, or perhaps a plan to populate the world. There's always a plan. And when you look at the African and coming down to Kenya, we have lost ourselves in that planning. And the reason I say that is because each time we've had a change of guard, we've had a new plan. So we've not followed through on much that we've thought through for health. So the first thing that we must do, as I answer your question, is we must come together and have a plan for healthcare that is perhaps 30, 40 years out, and we implement it in phases. When you look at the Chinese healthcare system, they don't have a landmark law that they can attribute their success to. But they do have 10-year plans that they can say, this is what we've achieved. We moved from the barefoot doctors to having primary healthcare centers down in the village, to an urbanizing society that has healthcare available even for the most vulnerable. So that's the first thing we must do. Coming to answer your question, we must ask ourselves, where does the greatest benefit lie in optimizing our healthcare system? Where does the greatest benefit lie? And I think a couple of areas. One, primary healthcare. I think it begins and ends at community level. So we must have that figured out properly. The second thing is we must figure out where our efficiencies are. The current stab at UHC is buttressed on 4 pillars: digitization, healthcare financing, primary healthcare, and commodity security. And I don't want to focus on commodity security because there are many good conversations that happen on the rest. For commodity security, we often will relegate it to somewhere else. And with that, if you don't have that figured out, you will have affordable healthcare that is unavailable. When you look at the top 38 most reimbursed surgical procedures by SHA, they tend to be orthopedic procedures, both of degenerative disease and trauma disease. I have not seen a conversation on how do we affordably source our implants, right? So that's the angle we must begin to have, because even back at home, when things are tight, you stop buying cake and drop down to what is essential for survival. Are we in such a situation? We are discussing about resilience and transition, meaning that we're in a tight spot and there is change that is happening. So we must figure out for ourselves those two things. The other thing that I'd like to mention is we must keep our operations lean. There is no free healthcare. I don't repeat that again. There is no free healthcare. Someone has to pay for it. And Kenyans were very wise. In the preamble of the Constitution, it says, we, the people of Kenya, commit to the well-being of the individual, the family, the community, and the nation. So they had figured out that health is important for them. And that said, it means that they were also willing to pay for it. The government, as the agents of the people, have now come and said that we think we can pay certain aspects of it. And that is great. I support that. That said, that means there has to be an environment of trust. And that has thoroughly been lacking. And as a private sector people, I believe we are the biggest influencers of government and any scheme that they are running. So we should be able to come together so that we're able to sell it to our fellow Kenyans, because the promise has been kept on our end. If those three things lack, we will go round in circles. So I will stop there and await the next long question.
Thank you, Tim. Thank you so much. So KHF has been very instrumental in having open, candid, a lot of roundtable discussions, just telling government, about the private sector and how we can integrate better to strengthen the healthcare system, because 1 euro in private sector and 1 euro in public sector is just 1 euro. So we need to figure that out. So finally, I want to come to Dr. Chris Baraza, who is the CEO and General Secretary of the Christian Health Association of Kenya, who is heavily involved in service delivery. And this has been impacted significantly with these changes in donor shrinking. And I wanted to ask you, how can African health systems strategically leverage digital health innovations and private sector, faith-based facilities, my apologies, have long been the backbone of healthcare delivery in underserved regions. I think, under Chuck, you serve generally, like, for example, Homa Bay County, where I come from. So, when we see these conversations, I get worried for my people, because chances are if you leave the main road in Homa Bay, you're going to a health-based facility that is a faith-based facility. And I wanted to find out, how is Chuck rethinking its mission-driven model to remain financially viable while preserving its commitments to equity and compassion?
Yeah, thanks, Noel. I want to indicate that Noel was my classmate. I thought she was pulling a tricky question on me by asking a question that I was not prepared to answer.
I could try.
Now that sounds familiar. No, thanks so much. So the Christian Health Association of Kenya, CHAK, is an association of over 500 health facilities in this country. And we work in the private, not-for-profit sector in this country. And we have a consortium in Kenya we call the Kenya Faith-Based Health Services Consortium that has a CHAK, that is Protestant churches. We have the Catholic Church that has KCCB with a number of facilities. And then we have SUPKEM, because the Muslims also have a number of facilities that they own. Douglas, the meds that we talked about actually is owned by meds and KCB and CHAK. So but we've been able to sort out that issue, the small issue you mentioned, in terms of visibility. I can talk about that authoritatively. And just going to your question, Noel, we are driven by the work of Jesus Christ, okay? The work of Jesus Christ. And if you look at Matthew chapter 4:23, it summarizes what Jesus did in this world. And there are 3 things he did. 1, he preached. 2, he taught. And then 3, he healed, okay? So driven by that mission, you find that in Kenya, for instance, we have a presence in terms of health facilities. We're just about 12-13% of the actual health facilities in this country owned by the consortium of faith-based. But in terms of service delivery, and that's where the point is, I want you to listen to that very keenly. In terms of service delivery, we reach out to about 40% of the Kenyan population. So it's a multiplier effect in terms of number of facilities vis-a-vis the actual service delivery. And what that basically means is that we are found in the hard-to-reach parts of this country, such that when we have a funding, reduction, the most vulnerable population that is served by the FBO space gets affected. And we complement what government does in many ways. Our model for the last many years, as CHAK, has been built on 3 aspects, which I want to quickly mention, and that's what we are basically doing. We are doing what we are calling business process reengineering. And we're asking ourselves, with these funding cuts that we have, should we do business as usual? Must we depend on the donors, whether faith-based donors or non-faith donors or government donors, Or should we be able to generate? And when I came in, Dr. Oluga was talking about how do we improve on our domestic resource mobilization. And that's our approach, actually, just thinking through how do we mobilize resources within this framework that we have to be able to sustain what we are doing. Our approach to service delivery is based on 3 aspects. One is cost-efficient models. So we are looking at how do we reduce the cost of production, and how do we move from being a consumer of healthcare to a producer of healthcare in this country. And that has very critical things that we must think through. How do we move away from being a consumer to a producer of healthcare? Because most African countries have actually been consumers of healthcare. But what does it mean to be a producer of a cost-efficient model? And one of the projects we are running, again supported by the Gates Foundation, is just looking at integration. And Bosire, you must be knowing about this. How do we integrate? How does it happen that we've been running HIV, it's a chronic disease, as a parallel program, and yet we have diabetes, we have hypertension, that are equally chronic diseases. So what we are doing basically is to integrate. We got some funding and integrating HIV in hypertension, diabetes, and we want to see what is the cost of doing that across both government and faith-based facilities. We have some private facilities. Probably by next year, around March, we should be having some good results that may just demonstrate to us that it's actually possible for you to integrate HIV in the chronic care model that we have. The second prong that we are looking at basically is quality of care. So, and our approach is asking ourselves this critical question: what makes you choose facility A vis-a-vis facility B? What are the parameters? Is it known? And the desire is that at some point, and probably using this quality of care bill that is being discussed, at some point we'll be able to compare Kijabe and KNH based on the outcomes of particular services, and not necessarily because Kijabe is cheaper and KNH is government. But we'll look at, I want to get services in this country, I want to have my hip fixed. I hope it doesn't happen as I get older. But I look at, can I look at how many hip surgeries have happened in Kitale, in rather Kijabe, and what are the outcomes compared to KNH, and I'll choose one over the other based on the outcomes, and not based on other parameters that we are using currently. So quality becomes very critical in this space. And the last one basically is just asking ourselves, how do we make these services more accessible? And there are many parameters to measure accessibility, financial access, physical access, so that we create an ecosystem. And the challenge I have, or rather the challenge we have as the faith-based ecosystem, because we have to agree that we work in a fragmented health sector in our country. So how, and the question I've been asking myself, and Matiko, I want you to listen to this very well. How does a patient in Kwale with a heart problem, okay, get to access services in Tenwek, because it has the best, as we speak now in this country. Actually, Tenwek is serving about 60% of all, is actually taking care of 60% of all cardiac surgery in this country. So how does a patient in Kitale, or rather in Kwale, who has a heart problem, access services in Tenwek without all these access issues? How do you use the digital platforms that we have to be able to see that patient in Kwale and come up with within the ecosystem for them to be able to get this service? I think if we think around it from that perspective, then we'll be able to manage some of these fundamental things that I've said. But let me finish by saying what Tim mentioned earlier. I think the time to act is now. We talk too much. Yeah, we talk too much. This issue of transition, when I was just finishing internship and I went to the HIV ward in the early 2000s, we started talking about transition. And no one ever imagined that actually USAID and CDC can actually live. And 2 months before Trump's stop work order, I was in a meeting, high-level meeting, and I won't say who that was, but one official actually said, you guys have been talking about this living for the last 20 years. You are not going anywhere. Actually, when now stop work order happened, I called him and asked, can you again repeat that statement? Because you're a government official, can you repeat that statement? But what does that mean? That it's possible that actually funding can stop, but how prepared are we as a country to be able to look for other ways of resource mobilization? Thank you.
Thank you so much. I think we're coming to the end of this session. And I wanted to ask everyone to just talk about what are the adaptive financing mechanisms in one sentence that Kenya can pivot and become more agile as we build our health systems. Because healthcare, education, transport are the three sectors that will never, ever stop working. But we have to optimize them so that they are at their best. So Matiko, maybe you can start by answering Daktari and my question.
Yeah, of course, behind the tent, I can have a conversation with Chris. Because it's I mean, we have a lot of challenges in terms of access, especially specialized care. It's probably just, maybe to answer your question specifically, the Kwale Kijabe conversation is probably something we could think about. How do we share resources and expertise across counties without necessarily saying that every county can have a cardiac center? Of course, the Kwale Kijabe is an extreme sort of case that we could address in terms of regionally. In the coast, how can we sort that problem to avoid that whole distance? But that's something that we should be able to take care of. We can have that long conversation, especially some of the work that we're doing at Savannah Global Health Institute in terms of how do we leverage digital platforms, not only to improve efficiencies, what I described earlier, but also to improve access in areas that we're talking about. So in terms of what is this new thing that we can do to adopt in terms of financing? Unfortunately, I don't think there's one country that has just got one mechanism that can actually fund healthcare. It's all about a mix of many, but what really matters is how well then all these many, there is visibility in terms of how they are being actualized, but the other important part is how trust and accountability is embedded within that kind of conversation. And so for us, it's around how are we increasing efficiency gains in all the systems that exist to fund our healthcare.
Thank you so much. Douglas?
Thank you very much. Screen says time is up, and really I appreciate that. Just one. Out of every 100 shillings that we spend, for example, in the HIV space in this country, 9.4 shillings is all that goes to prevention. And yet we keep talking about prevention is better than cure. Prevention should be a priority. We must put our monies where our mouth is. Thank you.
I didn't expect it to be that short. I think three things. One is that we must focus on the customer, that is a Kenyan, and ensure that services and their delivery operates around them. The second one is we must be flexible in our modeling of healthcare financing. An example I love giving is the top 10 companies listed in the stock exchange are in financial services, except number 4, who is EABL, who's on the other side of that coin, yeah? And between them, when you look at their book value in government paper, it's north of 450 billion Kenya shillings. And that's money, I think, if we are to be clever, can sort of be channeled into health, either by government policy or creating a bankable case for healthcare. That said, the final bit is we need policy stability and coherence. That has been my the bane of my existence, if I may say so. Each time we have the budget cycle in place, I spend a considerable amount of time at Treasury just trying to tell them that women are dying from PPH. And then they ask me, Doctor, what is that? So the trick we are now using from our virtual desk there is just giving them numbers. When a woman is not able to come back into productive to being productive. What does that mean for the economy? How many school days are lost when a preterm child is born because of poor nutrition, and the entire family is focusing on this child and kids don't go to school? What does that mean for us? So those are the numbers as a sector we must put together and create a bankable case for health. And the case is there. We are the 6th fastest growing supported service in the economy. The private sector has paid about 153 billion Kenya shillings in salaries. The government side is paying about 1 or 3 billion Kenya shillings. We are the 4th largest average salary in the economy. Of course, if you put the NGOs, that jumps to number 1. But we are the 4th largest, paying an average of about 1.8 million Kenya shillings. When you load the government side, it drops to about 1.3, and that brings it to about number 6. We've put in 15,000 beds into the economy in the last 1 year, and through SHA, perhaps another 100 billion Kenya shillings is coming to the sector. I think there's a case for banking in health. And finally, as I come to a close, I think, Frank, let's get a white paper out of this engagement that we can push as a policy position by Kenyans, because I believe we have an unlimited insurable interest in the sector. We also have a speakers roundtable, and I'm inviting your input to KHF. Because the chairman said when we meet, our problems must end. So we hope to end them. Thank you.
Thank you. Alice, I wanted you to talk about public-private collaborations and other alternative funding mechanisms as well, just from your office and what you see.
Sure. I think, first of all, just to agree with the panelists who've talked about truly funding healthcare. Most of what we talk about is sick care. We do a lot of sick care, but we call it healthcare. So even if you think about that, the example of PPH, if we truly did antenatal care well, we will identify high-risk women early, we will manage them well, and therefore we don't have to invest so much in the sick care. So I know that the government is talking about it, but I think we need to push the needle even further on how much is being allocated to healthcare. Other funding models, I think philanthropy is making a big push, not to replace government. We can never replace government, but this is a window of opportunity, and also for government to embrace this opportunity as an incentive to release more domestic resources. So I would champion for that. And there are many philanthropists who actually want to fund but don't know what and how to fund. And I know some bigger philanthropists like the Gates Foundation are creating a platform to direct philanthropists to areas which they can fund. So countries which are more organized are tapping into this very quickly. I will cite one of our neighbors, Rwanda. As somebody said, we have too many plans, they're very articulate. If you ask them, if they say, we need you to support maternal and newborn health, if you ask them how much and for what, they can tell you in one sentence. Very crisp. And so we have a responsibility as, now I'm not talking about as Beginnings Fund, as Kenyans, where we can to support our country to articulate that, to be able to leverage these resources. Thank you.
Yes, classmate.
I think health starts with me as an organization. And one of the things that we've unfortunately not done very well is actually inculcating effective governance structures in our design, in our implementation and all that. And I usually summarize that into 4. 1, do we have fit-for-purpose institutions that can deliver on our healthcare needs in this country? 2, do we have an accountability matrix that can be able to actually get deeper and tell us where the gaps are? 3, how are we translating global policies into local practice? And then 4, what kind of transformative partnerships are we having as we deliver our healthcare services? Thank you.
Thank you. Anita?
As I started, this government is run by interests. I hope that at one point we can be interested in making health systems work for our people. Imagine there are Indians who have access to proper health systems. Imagine there are Cubans who have access to proper health systems where we prefer to run to. Imagine if these health systems were accessible to our people. So for me, policies start with us, and when we ask what is in it for me in this deal, what is in it for me in this conversation, what is in it for me in this health system, what position do I get? I hope we can ask what is in it for our people, because that's what other people ask for their people. Thank you.
Thank you so much. So just to summarize very quickly, we had about data, we've had about aggregation for useful decision making from Anita. Matiko talked about interoperability, visibility, and increased transparency so that better decision making is made and trust is built, and sharing of resources and expertise. Alice talked about domestic resource mobilization and organization. I think that has not been very good, and that's where we are now with the integration that Douglas talked about. Leadership and accountability, and looking at sustainability and working, counties championing this as the key service delivery people, because healthcare is devolved, and the efficient HPT, health product and technology management. And then Tim talked about policy stability and coherence, which then optimizes patient facility, interaction, planning and decision making. But something he said that's key is that affordable healthcare is not always available, so we must strive to make it available. And that, ladies and gentlemen, concludes this very able panel discussion. Thank you very much, everyone. Prayer in Kenya, we have to pray.
Thank you so much, Dr. Noel and our panelists. Before you leave, we want to give you goodies as well before you exit the stage, and you've done a very good summary of the discussions. And I've also learned something new. There's something called sick care, and then there's healthcare. Yeah, so I've learned that one today. I also heard Dr. Chris talk about production, and it took me back to facilities like Revital Healthcare that are doing local manufacturing of medical disposable products. So as I said today, we are going to hear solutions, but also challenges, but also innovative stories. I want us to break for lunch because our time is well spent. Wango, you can give the gifts as the panels walk out, and then I'll also be guiding us. Yes, I'll also be guiding us on the lunch break. May I request that we are back here at 1:55, promptly. We have, so from here we are going to proceed for lunch. On the second floor of this building, you can either walk the stairs and not that many, or you can take the elevator. Let's go have lunch on the second floor. Just a side note, by the way, as Strathmore, you have to clear your plate, so don't leave your plate on the table. They are going to give you a side eye. You see, I'm giving you tips. So let's have lunch, and please be back at 1:55 because there's a virtual conversation we don't want you to miss. It's very important. So thank you all. Bon appetit, and see you at 1:55.
You can use the stairs on this side. Under the stairs on this side, you can leave your things here. They're safe. So please, let's proceed for lunch. Upstairs, you can use the stairs this side or the stairs this side up to second floor. Thank you. Please, let's proceed to second floor for lunch. Kindly, let's go for lunch. They're claiming haionekani. Hiyo time up. Toka tu hapo. Minimize hiyo. Minimize. Hiyo time up. Hebu nataka kuona kama inaonekana huko mbele. Have the conversation for lunch, kindly. Let me walk back. Okay. Hey, let's go for lunch, kindly. We need to be back here in a few minutes. Let's proceed upstairs for lunch, kindly. We can continue the conversations upstairs. Please, let's go for lunch. We should be back in the next 40 minutes. Let's go for lunch, kindly.
let's go for lunch. We have 20 minutes. It's a short amount of time to have lunch. Let's go upstairs to the second floor for lunch. I see you. I'm going. Bye.
Mic check, 1, 2, 3.
check. Mic check.
No, wait.
Let's settle down. Those who are standing behind, we are starting shortly.
Testing 1, 2. Okay.
Mic check. Mic check.
Ladies and gentlemen.
Ladies and gentlemen. Ladies and gentlemen. Ladies and gentlemen. Ladies and gentlemen.
Team sound. We're good. Ladies and gentlemen, if we can make our way back into the room to our seats, we're about to kick off the last 2 hours of today. And just before I introduce the program, I'd like to give our colleagues some time to make their way into their seats. I think in the interest of time. Team sound. Thank you. Testing.
Testing.
Okay.
Testing. 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 Testing.
My name is Sikelelwa Mdingi. I am a journalist and I'm with Global Health Strategies. And we work testing. I think we have a... The mic also went to lunch. The mic is recovering from lunch. Testing 1, 2, 3. I think we're good to go. Good afternoon, ladies and gentlemen. We are going into the second half of today's program. My name is Sikele Ramdingi, and I'm with Global Health Strategies. And we work with partners in health, where we communicate to help them with campaigns and advocacy. And health financing is one of our focus this year. We have offices in Nairobi and in South Africa, hence I am in this room here today. I think really to recap, we want to build on the conversations that happened earlier this morning, where a lot of our speakers really looking at how do we recognize this moment as the health community, how do we start newer conversation about reimagining public health, not only in Nairobi, across the continent. As a matter of fact, last week there was, I don't know if colleagues in the room were there was the conference on public health in Johannesburg, in Durban, South Africa, where a lot of the speakers and the focus was how do we reimagine public health financing. And to find that thread really resonating with the crowd here today has really been one of the highlights for me. I think before we really proceed and before I introduce the next speaker, I'd like just to give recognition to Strathmore University. As I was sitting there today, I had a moment where I felt I should be one of the alumni of this great institution. The excellence that was coming through the stage, but also how professional and seamless putting together this event has been. And I think I'd like us to give Strathmore a round of applause. I would also like to recognize the speakers that were here earlier on, including Doreen, who led the program quite gracefully. A round of applause to our previous speakers. And then also in the interest of time, I'm really going to be really quick in how I connect between the program, just to be able to give our audience, yourselves, an opportunity to ask questions in some of the different sessions. And to that end, I would like to introduce our guest, our next speaker, who's joining us virtually from Kigali, Rwanda, Dr. Ahmed Ogwal, who really needs no lengthy introduction, who is from Nairobi, Kenya, who has done amazing work in public health, including with Africa CDC, and is now putting on a new lens that's looking at communities through his work at Village Reach. And I'd like to ask the AV team to load Dr. Ogwal's video on screen. And we can listen to him. Thank you, ladies and gentlemen. Team is checking at,
Dr. Ogwal,
at the
if
back.
you could hold on a bit, we are sorting a few transitional points. We'll be starting in the next 1 minute, so if you could hold on a bit.
Okay, it does seem like the AV team is recovering from the lunch. But once Dr. Ogwal is ready to transmit, we shall continue with him. But just briefly about the afternoon program, this is hopefully going to be a looking forward session. I think when we had our guests earlier on, there was a lot of diagnosis around what the challenges are now. And the way the program has been curated, as you'll hear from Dr. Ogwal, he'll start talking about rising above the crisis. And then after him, there was discussion about how do we focus on the customer. So our fireside chat will be people we can call customers, who are the end users of the public health system, and they'll talk to us a bit about those experiences. And then lastly, there's a case for banking on health. And so the last panel will tell us about how do we use this window of opportunity, how do we look at transformative partnerships, and how do we strengthen public health systems as well. So I think that is what we're hoping to get, but more importantly, especially with our panel discussion, give this room an opportunity to ask some critical questions. Thank you.
Doctor, you can answer. You can unmute. You can unmute.
Dr. Ogwell, you're muted. If you could unmute yourself and try speaking. Dr. Ogwell, can you hear me? Wave if you could hear me, Dr. Ogwell.
Yes, can you hear me? Can I start?
Yes, you can start. We can hear you now.
I can start.
You can start. Thank you.
Okay. No, good afternoon, colleagues in Nairobi. It's a pleasure to join you virtually at this fine institution, Strathmore. And I hope that the day has been productive and will be very productive in the afternoon, even after that heavy lunch that was referred to. Let me start by just giving context to the message that I would like to give today from a community perspective. I had the privilege of growing up in part of my time in the village. And as young boys, one of the tasks that we needed to do was to milk cows early in the morning. And where the cows were spent the night was right next to my grandfather's hut. In fact, his window overlooked the cow pen. And whenever we will go to milk in the morning, he will always ask the question, have you asked the shepherd? And he will repeat it several times, have you asked the shepherd? Trying to understand his message, we went to our grandmother, and our grandmother explained that, the shepherd spends the whole day with the cows. And when he brings them home in the evening and knocks off and leaves the cows there, he knows the state of those cows, which ones are in good health, which ones are not, the ones that may be in a better position to give good milk, because there are many cows. And so asking the shepherd always gives you much better results, because then you aim to milk the right cows who have the right amount of milk, and therefore you get much better results. And that's where we are today as a continent. We have a lot of conversation going on, and I will go beyond health financing. We have a lot of conversation going on within the health space, and we are not asking the shepherd. And for this continent of Africa, the shepherd is me and you. And therefore, as we utilize this opportunity for reimagining what we can be able to do on the continent, we need to be good shepherds, and we provide the right information so that we get adequate milk from the cows that we are looking after in terms of health for the continent. In January this year, we were woken up quite vigorously. I like to say that it was a heavy slap. And when someone is sleeping and you slap them very hard, they wake up very confused in the beginning as they get their bearings. And that's where we were. We were slapped sometime in January. We've been in a bit of confusion, and it is time really to let go of the confusion and start focusing on how do we ensure that the period going forward is going to be beneficial for our continent. We have a lot of conversations on Africa's health sovereignty, whether it is the Lusaka agenda, whether it is health financing itself that we are very topical about of late. We need to refocus our efforts so that they are results-based. And I say results-based because Africa doesn't have the luxury of time. Disease burden is increasing. The repertoire of diseases is broadening. It was infectious diseases before. Now non-communicable diseases, injuries are increasing. Mental health is at its highest level ever. and we need to ensure that we reclaim the narrative of what is wrong on the continent. We reclaim the narrative of what should be done on the continent. We need to reclaim the narrative of how what is to be done needs to be done. And I will start there from the model. We are utilizing models for healthcare delivery that are not necessarily African. We are utilizing models for and strategizing that are not necessarily African. And this is where the first challenge comes. When you're using a model that is not understood by the majority of your people, then during delivery, you will have a challenge in providing healthcare. When you're training health cadres that are quite expensive to train, but also difficult to deploy to where they are needed, then it means you're training for a very small group of people who are in our urban centers. When the indicators that we use are not African, a good one is BMI. For those of you who come from communities that have huge structure, your BMI will constantly read it is above normal. We need to start ensuring that the indicators as well are speaking to us as a community in a way that we understand and in a way that accommodates our context. Reclaiming Africa's strategizing, planning, delivery, including the models, is not only urgent, it is one of the imperatives that we must address during this time after that big slap that came our way. The second is we need to step back and not just talk about health financing, because delivering healthcare is beyond money. There is a lot of resources that we already have. We have institutions on the continent. We have experts on the continent. We have infrastructure on the continent. We have innovations on the continent that we are hesitating to use because it doesn't fit the model that probably the globe is looking at as the gold standard. If we want to progress faster, then we need to utilize every resource that we have on the continent in a way that actually serves our interests directly before utilizing ideas and innovations that have come from elsewhere. We have enough on the continent to be able to begin that particular journey. And sometimes simplicity is the best of innovation. I'll give you an example. During this last Ebola outbreak, the first samples for testing the responsibility was charged to us as Village Reach. And rather than use air or vehicles, very difficult terrain in the DRC, especially this central part of the DRC where this outbreak has occurred, we decided to just use motorbikes. And there will be a chain of motorbike riders passing on sample from one hand to the other. And in less than a day, the samples were in Kinshasa for testing. Innovation doesn't have to be complicated. We could have used drones. We could have used planes. But the cost of running the drone, the cost of flying the planes is way, way above what the government could be able to accommodate. And we decided to go by exactly how the communities live, how the communities travel. And we were able to deliver those samples in good time. And on confirmation, the country could be able to prepare and respond appropriately. We need to reclaim this narrative so that Africa does it according to our local context. The third and last point I'd like to make is when the discourse around health financing continues, when the discourse around where the money should be able to come from continues, we really need to start looking inwards when it comes to finances. And my thesis is that we don't start by mobilizing more money, we start by optimizing what we have. The level of wastage, and I hope there will be some concrete research being discussed at this forum or others, the level of wastage in the health systems on the continent of Africa it's so high that there is no way we can be able to improve health delivery if we don't address wastage. And wastage can come in many forms. Some call it corruption, others call it different names, but that wastage needs to be arrested. We must start with what we have. How do we optimize it, make it efficient, ensure that it is delivering shilling for shilling, dollar for dollar, pound for pound, what has been planned for. And in those efficiencies, we address the models in which we use, and in addressing those models, we utilize the local infrastructure expertise and other resources that we have on the continent in this period beyond the health financing crisis that we are seeing globally. The continent is not poor. The continent has adequate resources to begin the journey of fixing the health sector. The continent is not devoid of experts and the expertise. We have, it may not be enough, but we have enough to be able to begin designing our own programs, prioritizing it using our own context, and ensuring that the delivery is being done using our own models. The continent has a lot to offer the world, and we should not wait to be invited to make a contribution. We should not wait to be provided innovations to adapt and deliver. We should not wait to be informed of what is new in as far as global health is concerned, because we have enough of that on the continent. We just need to harness it and deliver it in a model that is much less in cost than what we are seeing today. In ending, I would like to suggest to you, as experts in this space, that as we speak about African health sovereignty, let that the word sovereign mean something. Let it mean something for Africa's quest for improved healthcare. Let it mean something in as far as local ideas are concerned. Let it mean something in as far as local resources are concerned. And we have agreed that local resources goes beyond just money. Let it mean something when it comes to local leadership. Let Africa's health sovereignty and all the conversation we are having around sustainability not end at phrases and good meetings and good calls. Let it actually translate into what is done, what we do within our institutions, what we do within our countries, what we do within the continent. Africa's health sovereignty. Let the word sovereign mean something, and that something has to come from us. Let that something be simple enough, and let that something cost much less than we have been made to believe that healthcare can be able to cost. Efficiency needs to go together with the sovereignty that we are talking about. But let sovereign mean something in Africa's health sovereignty. Thank you very much for your attention.
Thank you so much to Dr. Ogwell, and apologies again for that glitch when we started, but I think it was worth the wait, especially the messaging that he's giving us around really Africa, the time is now, and how do we find solutions to the challenges. And then our next speaker is going to be a fireside chat. As I mentioned earlier, technical sabotage. I think we're fine. So our next speaker is going to be a fireside chat that's going to be led by our colleagues from Willow Health Media, who happen to do amazing work in health communications. One of the things that they were doing, actually, they were one of the few media houses, not just in Kenya, but across the continent. In our office in Joburg, we were looking at the work they were doing and telling the stories of the communities that have really been impacted by the funding cuts. Behind the numbers are real stories. There are people's lives, there are job loss, but at the same time, there's access to healthcare services where there's difficulty accessing those centers. So I think that's why we want to turn the program around, where we bring the human face to these discussions, so that when we have our last fireside chat to close the day, when we're talking about partnerships, at least we've had this diverse background of voices telling the story for today. Over to you.
Good afternoon, everyone. Welcome to Unbowed Stories of Resilience. We're going to switch it up a bit. All morning we've heard about the numbers and the policy. Now we want to switch and listen to the people who actually live these impacts of these systems on a daily basis. I'm going to invite two incredible voices of resilience. Joseph Okutoi, who is a community counselor and peer educator, and Jerop Limo, who is a HIV advocate and 2025 goalkeeper. So Joseph and Jerop, please join me. And as they come in, I'd like to give a warm thank you to our hosts for creating the space for these conversations, and to everyone here who continues to champion health equity across Africa. And let's dive right in. So I'm going to start with you, Joseph. You've spent years supporting people living with HIV. Maybe you can give us a brief introduction of yourself and then just dive right into it. Tell us what happened when the funding cuts came in. Suddenly programs were closing, jobs were lost. You can take us to that moment and tell us what it meant for you personally and for the community that you serve.
Ladies and gentlemen, good afternoon. Thank you for this time. Actually, my name is Joseph Okutoi. I've worked in different organizations since I left the college. I started with Redeemed Gospel Church. After that, I joined MSF. I worked in MSF, that is a French clinic in Madari. And then after that, I've done Liverpool on contract basis. Sometimes you do some research about the community, and that is how it has been with me. I'm a father of 5, and that's all. I think what I would like to highlight, the way my sisters just asked me to, it is about what has gone within the communities. Most of my life, I've worked within the communities, name them, Madari, Korogosho, Mukuru, and all that. Those are the areas that I've actually worked in for most of the time. And actually, when we meet in a forum like this, we need to focus exactly on what is on the ground. Because I believe where I am here, 1 or 2 people or more, we have interacted in one way or the other. So I've done this within the communities, and most of my lifetime, it has been within that. I've been a peer educator, I've been a counselor within the same system. Now, within this particular area, actually, I've faced challenges. And if I mean challenges, I've really faced challenges. Because sometimes you work whereby you can't access the ambulance. You find that some clients cannot actually meet their daily challenges, like food, water, all that. You see, all those things, it is a component of its own. You find yourself venturing into that a lot because it is you and you alone, nothing else. So you see, you have to make sure that you do the counseling part of it. You need to do the home-based kind of it on this particular patient. And it's not 1 or 2. It's across the community. Now, the facilities around that we have had have done a very fundamental job within the communities. You find that sometimes when the freezing came, actually, it was like, now where do we go? What do we do? So those are some of the questions that we asked ourselves. Because you woke up in the morning, you know very well, you are going to the facility, you reach there, you find every door is closed. Now you don't know what to do. You call every call, nobody will pick it. So you find like you are nowhere, you are nothing. Yesterday you are someone, today you are not somebody. So it has been a challenge to people like us. To me, myself, I've taken it as part of my life because these are human beings. They need my help. And I can't tell them no, because if I tell them no, most of us here, we are medics, we are medical, we do understand what it happens. If a patient believes in you, the patient will walk in the clinic, will say, I don't want to be seen by so-and-so, I just want so-and-so. Because this person believes that you have the secret of his or her life. So the person won't leave you. The person will remain believing in you. The same thing has happened to, like me, and my other colleagues who are outside there. A patient has believed in you. Patient will call you even as late as at 2 a.m. Now, the person will explain the way she or he is feeling. Now, you have to do an extra job. Extra job, what do? You have to advise that person over the phone. The following day, you have to wake up in the morning, you go and visit the patient or the client, and they understand the way she is. If it's not, then you have to make it clear that this person has to reach a health facility because as a counselor, I'm not a doctor. So you see, I can't administer anything. I have to make sure the client lands to the health facility, the nearest. I think that's all with me.
Yes, that will do, Joseph. Thank you. Over to you, Jerome. You've been at the front lines of advocacy, standing for dignity and better care for young people. Maybe you can tell us about your journey into this work. What first moved you to speak up and push for change?
Hi, everyone. At least you've woken up. I can see people ate ugali and rice. So I think I deserve claps because I'm the first young person to stand on this stage today. Yeah. Again, you've woken up even more. Yes. So I, just like Joseph, started off as a peer educator, coincidentally at LVCT as well. And truly, I cannot point or explain what led me to dive deep into civil society work, or rather advocating for the rights of communities. But I would say it was getting to a point where you truly understand that biomedical interventions are no longer enough, and that when a recipient of care or a person living with HIV or a person with any mental health issues or a person with TB walks into a health center, that the system truly looked at them as a person with TB, a person with HIV, and nothing beyond. And most of the time, when you would interact with this person 3 days later or 3 months later, you realize that the main problem they were going through that was truly affecting how they took treatment and how they were adhering and their ability to even come back to the clinic if they needed to was things that was outside the biomedical aspect. It was maybe they didn't have transport, maybe they don't have food at home. For adolescents, probably you're coming from a quote-unquote unsafe or unstable home. So the social, structural, economical issues that were truly at the center of the health and wellness of this individual and truly influenced how they thought and practiced the information given by the doctor. And for me, it was that their health system was not looking at this person beyond the biomedical aspects. And that is what pushed me to the space 8 years since, and now I lead a youth-led organization that works with adolescents and young people living with and affected by HIV. And a lot of my work is truly centered around ensuring that their voices and the voices of the communities are represented in rooms and conversations like this, even though during the previous panel, someone said, we speak about these things and we'll go to another session and we'll speak about the same thing. I've been hearing these conversations for 8 years, so best imagine. This is very familiar to me, but at the end of the day, when we leave this room and go back to our homes, that is where the work starts. That's where the action is actually needed, because this is all said, and at the end of it, something has to be done. So for me, it's to be able to ensure that communities are truly not beneficiaries, and we shouldn't look at them as beneficiaries, but we should look at them as equal stakeholders in any health conversation, because we preach to ourselves, we know the response, we know the health systems, we are privileged enough to be able to know who to call and where to knock, but the truth is many of our communities don't have the privilege that we have, and that's why I do the work that I do.
All right, so I think we are aware, or if you're not, we're going to be aware, that according to the UN AIDS 2025, Kenya has already seen service disruptions in at least 25 counties after donor cuts to HIV programs. And that means that up to 5,000 community health workers have lost their stipends, and counseling services have also shrunk dramatically. So based on your experience, Joseph, which actually puts a face to these numbers, you've continued to volunteer as a counselor, even without pay. Could you share how the community and people living with HIV and the caregivers who support them have been responding to the disruptions in health service?
Actually, at the moment, the issue is most of the cases that were seen sometimes back is coming back, because we have a high rate of people defaulting. We have a high rate of TB today. And you see, some years back, we had the multi-drug resistant TB. And it was, where I used to work, it was really affecting the organization in general. Because to treat only one person with the MDR TB, actually it was about 2.4. And it was really affecting the organization. Meanwhile, they continued, and the rate was down. They introduced the gene expert machine within the health sector, and actually the TB was going down. But in the recent past, a few months ago, we've had such cases increasing. Now, me as a counselor, you see, I have to talk to these guys to go back and take the medication, because that's the only way that I can do it. Some of them refuse because, for example, the organizations, when they were on the ground, actually they used to be given some food, small tokens, at least for their upkeep, because they are on medication, and today there's nothing. Now, in one way or the other, the health sector now, it has taken the system back to level 1 hospital, who is the community health provider, who is a CHP, which is a very heavy job on this person called community health promoter. It is a very heavy job, because this person knows exactly what is happening in the household. Yet, the person in the facility will not understand exactly what is happening in the facility. So you'll find this person not taking the drugs. I'll chip in as a counselor, try to educate this person, try to counsel this person to come back on the treatment. But how long am I going to do it? Because it's not one person, it's not two people, it's a couple of people. So you find it's a very big issue within the community. And you see, we are in a medical institutions, most of us. We need to understand the person within the community understands the community better than any other person who is coming for the job. Are we together? This person within the community understands the community better rather than somebody. For example, You are working in Madare, and yet you yourself, you stay in Runda, but you are coming to work in Madare. So you are in Madare because you want a job, but you are not in Madare because you want to help somebody in Madare. Are we together? Somebody will work from Bagadi because he needs a job. The person stays in Kahawa West. You see, that is a difference. So you find people like myself. Once the retrenchment came, I moved down to the community because I've worked within the community most of my time. So it meant me to move back to the community and understand fully what is happening within the community. I do it voluntarily. Why do I do it voluntarily? Because they're human beings like myself. I need to understand them better than myself. So all of us, we have to take that initiative so that at the end of the day, we need to achieve the goal. Because these are our brothers, these are our sisters, these are our children, they are our relatives. We need to understand them.
Thank you, Joseph. Still on those numbers, we've seen reports showing the aid freeze triggering what some have called a silent HIV crisis. There have been stockouts of ARVs, fewer peer counseling sessions, and outreach programs have shut down, like Joseph is describing. Given your work in the community, Jerome, how have you seen these impacts manifest among young people who relied on those systems? How are they coping, and what keeps them going when access to care becomes uncertain?
In the morning panel, someone said that we operate in silos and we have parallel systems, which is true. But I think for the HIV response, there is some form of justification of why a parallel system existed in the first place. While now we say HIV is a bit normal, which is relatively to most of us who are medical practitioners or have interacted with programs, but to many people, it's still that one thing you do not want to be associated with. And decades ago, you can imagine how bad it was. People were dying, nobody wanted to come near a person living with HIV. We sang in school, I sang in school, AIDS is a killer disease, and I saw people actually dying, right? So it was created to be able to provide a safe space for communities to be able to access quality HIV care in spaces where they would not experience stigma and discrimination or be violated. And sometimes we make this joke that before, many years ago, people used to sit at the waiting room and the doctor will come and say, watu wa ukimwi, east side, you know, watu wa kisonono, east side. And now we tell it as stories, but those were the same experiences. Communities who have pioneered the response experienced and had bad and terrible experiences with the health system, which was in turn supposed to not give them bad experiences, and hence the different HIV response system. Years later now, and everyone has said, talking about sustainability and sustaining a system as a country by ourselves is not a conversation that started today. Started years ago, many years ago, and we all knew that the donors would come and they would go. Of course, there is no way I can hold a president of another country accountable. They do not even know who I am. They have no ability or legal commitment to be able to take care of my needs. But in this country, I have the ability to hold my leaders and policy makers. We've been told to call them politicians. So we have the ability to be able to hold them accountable, right? The freeze came with a lot of things, from healthcare providers, both clinicians to lay healthcare workers. These are the community health promoters, these are the mentor mothers, expert mothers, and in adolescent health, we have peer educators and peer champions. These systems existed to be able to ensure that communities are able to navigate a complex health system. So one of the things we saw was many of these providers who were being supported and paid by other donors having to stop their work. You can imagine waking up with a job and sleeping and waking up the following day without a job. It was quite chaotic. Secondly was that there were a lot of programs. One of the best programs I keep on talking about is the DREAMS program, one that was empowering adolescent girls and young women through prevention, messaging, awareness, support, including school fees, and ensuring that you lower their vulnerability rate to HIV, and many other programs. But for people living with HIV, it was the chaos of now who will offer services to us. And Joseph said, when you trust clinician, and trust me, even for adolescents and even for most of us, you will keep on going to that person because that is the person you trust and you're open with. So for us, those are some of the things we have seen. We truly have had shifts, ups and downs, and I like Douglas because Douglas mentioned that at some point we had stockouts of nevirapine, and we truly did experience that. But the good side of it is that as communities, we did not sit in our chairs and cry. Yes, we cried, but we woke up to go and make sure we support those who don't have the privilege of accessing information and support systems like us. So you ensure that the young person knows you don't have to skip your medicine because you want it to last longer, because someone closed the tap, there will be medicine. That you do not need to fail to go for your appointment because you're assuming there is no clinician, so reminding them that they have to go for their clinic to put in place to ensure that our communities, despite the funding shifts, they still know that there's a system and there are people who will be able to provide care for them. And for us is to hold government accountable to ensure that they actually ensure that we don't have gaps in the HIV response despite the funding shifts.
Thank you, Jerop. As we close, I think we've been listening to them both, and it's very clear that resilience has many faces. We've had stories of courage, endurance, innovation, and I want us to connect back to the bigger picture of why we're here. To Joseph, what lessons do you wish our country and other African countries would learn from this moment, especially regarding funding for essential health services? And then Jerop, maybe you can also tell us if you had the attention of global funders and health ministers right now, what commitments would you urge them to make to safeguard the lives and dignity of people living with HIV and health workers delivering these services? So we'll start with Joseph. You'll take a minute, and as you respond, you can give your closing remarks as well.
On my side, what I would like to emphasize and talk about is about Kenya as a country, because we have been given mandate to manage ourselves. That means since we left the colonial system, we came into being as a country. What we need to understand from the word go, we have these diseases with us. And hence we have the diseases with us. We have to get a mechanism on how to deal with it as a country. So to me, to everyone in this room, I'll just say, as we are, we need to understand. We don't need to chase everyone, but we need to understand ourselves for a better change. Secondly, we don't need to chase every coin, because if we do that, we shall remain crying for help. And at the end of the day, our people will continue suffering. Our people will continue dying as we bury them. So the only thing is we have to get a mechanism on how to work on our people as a country. Then we need to understand as a continent, an African continent, how do we take it as part and parcel of our daily living. Thank you.
Thank you so much, Joseph. Jerop, in a minute.
Resilient health systems cannot be made or founded in boardrooms. They truly can only be made in communities. And I think as a country, we keep on saying we have beautiful policies, but they are decoration for the shelves, to be honest. So we need to move from paper to actual action, because these policies can be able to guide us to better success. But lastly is to truly, truly center the voices of the communities. I wish we had the opportunity to speak when our leaders were here so that they would have heard us, because I feel like I personally had a message for them. But trust is at the core of health. We cannot ask people to pay for an insurance if yourself, you're not using that said system. So we have to build trust with the communities, trust that has been broken for decades. This is between communities and government, but also go to the ground and ask people what do they want. We need to stop imagining and assuming and using our biases and our beliefs and what is in it for us to make policies and design programs.
Thank you so much, Joseph and Jerome. To everyone listening, I think what we've had here today is a call to act with humanity and not just strategy. I have been your moderator, Sarah Okoro. Enjoy the rest of the afternoon. Thank you.
Thank you so much. A round of applause, ladies and gentlemen. Before you take your seats, I'd request Professor Wafula if you could come and issue them a small token of appreciation on behalf of Strathmore. Yes. Yes.
Next time we'll try and have a fire so that we have a proper fireside chat.
So at the same time, I'm seeing a couple of you on your laptops, a couple of you on your phone. Prof, just continue with the smiles. It's time to stretch. I know you've had a couple of meals. Before we go to the next session, as we set up the stage for the next panel, so I'd request, as we continue, the photographer the fire has been too, yeah. So he's come. Let's give him a minute. The fire has been too much, so just understand. Thank you so much. And finally, our able moderator. At the same time, the rest of you, if you could just stand up. If you could just stand up. Just stand up, stand up, stand up, stand up, stand up. We've been speaking about resilience. I see a couple of you stretching. Don't start yet. It's me who's telling you how to stretch. So don't be seated. Don't be seated. Those with the laptops, those with the phones, you're here to listen to the panels that are here. So shake off a bit. Just shake anything. Try to shake anything on your body. Shake anything. Hey, interesting. I'm seeing a couple of guys shaking their eyes. Interesting. So let's start with the shoulders. Just gentle shoulder roll. Gentle shoulders, just shoulders. I can see guys from the western part are doing it nicely. Follow what Dr. Miriam is doing. I don't know, just gently put it to the front, like this. Just follow what I'm doing, to the front. You cannot follow me with my shoulder. To the back, to the back, to the back, to the back. Wonderful. Just like systems, I can see you're struggling with the shoulders. Interesting. All right, let's stretch on the side. Stretch on the side. Just bend a bit like this. Bend a bit. Put your hand up. Put your hand up. Try to go down like this. Try to go down. Try to go down. I can now assume your ages. Wonderful, wonderful. Switch to the other side. Switch to the other side. Switch to the other side. Switch. Switch, switch, switch. Go down. If this able gentleman is going this far. Wonderful, wonderful. Now go to the neck. Let's gently tilt the head to one side. Just the head to one side. Then the other to the left. Put your chin towards your chest. Chin towards your chest. I can see guys doing like this. Chin towards your chest, chin towards your chest. Wonderful, wonderful. So even in transition, we stay grounded and focused. Finally, your arms, stretch them out. Both of them, both of them. If you could follow what Prof is doing, he's calling the money back. After it has gone, stretch it, stretch it, stretch it. Now, interlock the hands together. The opposite side, like this wonderful lady is doing, like that, wonderful. Put it on top of your head. Stretch on top of your head, top of your head. Straight, straight ahead. Wonderful, wonderful. Straight ahead, straight ahead. Now finally a deep breath. Inhale, inhale, inhale. Inhale until I say inhale. Wonderful. Exhale, exhale, exhale. Exhale, exhale. Wonderful, wonderful. Fantastic, fantastic. Now to your eyes. Roll your eyes. Ah, wonderful. You can have your seats. Back to you.
Thank you. Taking after his namesake, Nelson Mandela, he woke us up from slumber. Thank you so much for that. And I think then we are actually, believe it or not, at our final panel for today. I think we've had a lot of discussions, very interesting topics, and I think the best way to tie it together is to really look at partnerships. But before I go to that, I really want us to give a round of applause to our previous speakers. I don't know if it's the journalist in me, because I like other people's stories, but it was my favorite session for the day. But more importantly, because our speakers showed us the two sides of the age spectrum, a very young person who's affected and a community worker who has decades of experience. And I think that's why then, as I call over our next moderator for the last panel discussion, we look at how do we use partnerships to really make the impact of the aid cuts less harmful to our communities, but more importantly, how do we move forward? I think our 2K generation speaker asked us, what is the action? And I think that's where we're going now. And I'll hand it over to you, Jane, and you will introduce your panel. Thank you.
Good afternoon, everybody. Seriously, good afternoon, everybody. I am very happy to be introducing this next panel because the speakers that were here, Cherop, I think she spent half her time bashing them. So the politicians are coming on stage. The policymakers, really. Building on the strategies and examples of adaptation to reduce financing discussed in previous sessions, and in just this one we've had, this panel will discuss on guiding policy and planning for the future of Africa's health systems. I think I had a quote the other day that when health is absent, wisdom cannot reveal itself, art cannot manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. So these next panelists, that is what they will be seeking to address. So our first panelist is Katra Ali from the Council of Governors, Director of Health Services. She has been a registered community health nurse. She holds a master's degree in community health and development, and has over 25 years of experience as a community health specialist. Please welcome her with a clap. Our next panelist is Ms. Maureen Murenga, who is the Vice Chair, Country Coordinating Mechanism for Kenya for the Global Fund. Please welcome her with a clap. Maureen is a passionate advocate for the health development and human rights of women and girls. She has a background in program management and community development, and she is a pioneer amongst the young women and adolescent girls living with HIV movement in Kenya, and a fierce advocate towards ending pediatric HIV. Our next speaker is Ms. Lucy Gathoni, who is a technical advisor at the Financing Health for Alliance. Financing Alliance for Health, excuse me, I've gotten it right. She supports governments and partners in designing sustainable financing strategies for primary and community health systems. She has contributed to several high-impact initiatives focused on innovative financing models for health system. Her work reflects a commitment to equity, sustainability, and strengthening local capacity to deliver essential health services. Please welcome her with a clap. Our next panelist is Dr. Elizabeth Gitau. We are coming, we are coming. We are going to land, we're going to land. Council member, Kenya Medical Practitioners and Dentists Council. Dr. Elizabeth is a medical doctor with over 10 years experience in clinical practice in both the public and private health sectors. She currently serves as a consultant in various health systems, strengthening initiatives focusing on healthcare financing and public-private engagements in the health sector. Please welcome Dr. Elizabeth with a clap. And we save the best for last. Also because, you know, women nowadays, we excel in male-dominated fields. You know, the way men used to exclude us. We were going to practice, but because we are the better gender, we decided to be inclusive. Which brings me to our next panelist. Dr. Kadondi Kasera, who is the country lead tackling deadly diseases in Africa program, phase TDDAP2, Palladium. That sounds scary, okay? Dr. Kadondi spearheads efforts to strengthen health security and resilience across African health systems. In this role, Dr. Kasera provides strategic leadership on disease surveillance, emergency preparedness, and capacity building, working closely with governments and partners to advance sustainable solutions for epidemic prevention and response. Please clap for Dr. Kadondi. And our final panelist is Ms. Pauline Irongo, who is the Director Policy and Public Affairs at Pfizer. Pauline is a policy and advocacy leader with 2 decades experience engaging global organizations and governments in the African region, advocating for stronger policies and investments in women's health and children's health and global health research and development. She has advocated extensively for civil society to be a driving voice behind government decision-making and policy actions. Please welcome Madam Pauline to this panel. And lastly, I'm your moderator for the day. My name is Jane Mwangi. I may be the only non-medic in the room, which should make for an interesting discussion with yourselves and the policymakers, because they have to explain it to me in English, not in healthcare, which should be useful, I imagine. So we will start. I'll start with you, Madam Katra. As counties increasingly shoulder the responsibility for frontline health delivery, what innovative investment strategies are emerging at the sub-level level to strengthen health systems? And as you answer that, I'd like you to consider what the previous panelist said. I think her name was Cherop. She said, we've had these conversations for decades. So in light, answer that question with that lens in mind. Thank you.
Thank you so much, and thank you for actually inviting us to this. I'm so glad that we are very powerful women here with one man. I hope he will. I hope he can neutralize. Yes. Feel safe, Dr. Kasera. Maybe just to start with the last question, and I think I was just having a conversation with Professor Wafula right now when we were sitting there, and the biggest challenge we have in this country is we like developing very good documents, but the problem is implementation. Every time we walk into very big or good meetings like this one, we have an action point which are never implemented. So where do we start? I think we need to basically change our strategies and see how we can be able to make a recommendation that is workable, as we also make some of these resolutions so that it can be implemented by the actors who are supposed to be taking lead in those action points. Maybe that one I can be able to answer it like that. We do very good documents, and sometimes you go even out of this country to go and benchmark in a country who are doing very well, but just later on to be told that, you know, that document and that concept, we stole it from Kenya because that document was there and it was never implemented. We have stories, it is fact, it's fact, it's fact, it's fact, but basically we need to change our strategies. Coming back to my point, in terms of strategies for innovation, I think we all know that health is a devolved function. The Schedule 4 of the Constitution is very clear. It has given county government their mandate, and it has also given the national government their mandate. We are two levels of government, but we work in consultation and in collaboration. In terms of investment, a lot has gone into health sector after devolution. We can basically name them in terms of upgrading infrastructures. We have diagnostic services that have improved. We have improved access to healthcare. Probably before, like, you may find a mother traveling all the way from Mandera County, which is 800 plus kilometers, to Nairobi to basically seek regional services. So things have improved in terms of human resource. When you look at Turkana before and now in terms of human resource, things have basically changed. So we all embrace devolution, and we have to support devolution. So in terms of investment, I can basically say a lot has gone on. I think some of you, probably the health who are seated, the health, those who are in the health sector seated here, there is a big investment that has ended. It was called Medical Equipment Service, MES equipment. But right now we are jointly doing another joint equipment with the national government. It is called National Equipment Service Program, and that is a heavy investment. By actually doing that, counties basically will just ask for the kind of equipments they want, and the vendors basically go and place those equipment so that we can be able to have the issue of equity. Probably if a county feels that we have a gap in diagnostic, they can be able to put a very modern infrastructure for diagnostic, which actually will increase the investment for the county. You don't need to send patients to other counties or other facilities to go and seek services which are available within that facility. In terms of other investment that we are basically doing is counties right now have autonomy. Most of the facilities in the counties, like now 44 counties out of 47, have basically invested in FIF, and the county assemblies have passed that FIF, which now is helping counties to have that autonomy of spending money. Before, remember, like monies that are also generated within the facilities basically goes to the county revenue fund, and so then it may not go back even to that facility. So each facility probably that has passed that FIF have actually autonomy of spending their money and not putting into consideration. I know I'm seeing some health guys around, the director wa Nakuru. We have delay in disbursing from Exchequer. Sometimes counties can stay 3 or even 4 months without getting money from Exchequer. So in terms of innovation, by even coming up with that FIF, service delivery still continues. A lot of partnership, public partnership is private-public partnership is also ongoing, and a lot of investment case even have been developed by many counties. Like when you look at Makueni now has an investment case which has really attracted many partners. And when you look at Makueni, even just go to their website, many partners have been attracted to Makueni to basically go and implement in their investment case. Look at Kisumu, what is happening in terms of community health promoters. They have basically created a dashboard in terms of investment, and they have so many things that needs to be monitored, and many partners are actually showing interest in terms of how they can basically tap in and support those counties. Without that, even just coming back to the COG, Council of Governors, we've gotten into partnership with many partners, including Professor Frank, who is seated next to me, Open Fences with Strathmore University, and we are doing something, supporting some few counties in public-private partnership. And basically by getting into the MOU, that means like they have to work also through us, the counties, because the Council of Governors have a convening power to bring on board. Probably if you need Governors 47, it may take me an hour or 2 hours to basically convene. If I need chief officers of the ministers of health, it just take me shortest time possible. So, and these are the people who actually sit on the table to basically make decision for the entire 47 county government when you have the leadership. So through private-public partnership, we are able to do a lot, and we have good stories basically to share, even in terms of that. Probably when you walk into or you just log into our website, of Mariva platform, you see a lot of innovation, not only in health, but also in other sectors. We document what the partners are doing with us. We document good stories that happen as a result of investment that has happened through probably the partners and the counties themselves. Even governors, most counties have priorities health as their biggest agenda. Remember, if you are not healthy, then you are not a healthy population. Still, it will be very expensive. We can even talk about preventive measures. Most of the time, we always think about curative. You only run to a facility, or probably facilities are providing curative services. Nobody looks into preventive. And governors have basically, or counties have basically invested heavily into preventive measures, because when you prevent diseases, then that means actually you have a healthy population, and you may not actually spend a lot in curative. That is probably for the start, I can say that, but there is a lot, and still as I'm sitting here, you can basically also log into our Marifa platform, see the investment that has happened, see the good public-private partnership as a result of that, what came out. And because counties are also at various stages, they learn from one another. Probably if a partner has invested in this, another partner will come and continue with that. Otherwise, he may not go back to where the other one has left. So a lot of sharing of experience, sharing of innovations, and many other good things are happening on our website, and that is probably what I can say for investment. But basically, as a result of devolution, health has improved. Indicators for health has actually improved. When you look at KDHS 2022, the indicators for health has actually improved. I know the only thing that was not there was the maternal mortality rate, which I know Kasora is looking at, and probably that one, we will be told by the ministry why it was skipped. But it is not politics, but it is something that we also need to know. But basically, those indicators improve as a result of investment. You can only improve health. Health is expensive. You have to invest in health for you to get good outcomes. And that is basically what is happening. Thank you.
Thank you very much, Katra. Is the ministry present, by the way? So we can't check. I'm just playing with you. But it's very nice to hear the changes that have been made. Very good to hear that there is a tracking system. It is also quite amazing to hear that there is a place, a single source of information where this can be tracked. When I come back to you, we will be discussing how that can be disseminated to the local mwananchi, so that we stop fake news. They know where to go for help. They know what is available and what isn't. But congratulations on a fantastic job so far, and we hope that you can continue the same. I'd like to go to the only man on this panel, Dr. Kadondi. Coming off what Katra has said, we can see there's a lot of nexus between national and county, there's a community, there's a whole ecosystem around health. So I'd like to ask you, how can global health partnerships be restructured to better reflect the realities on the ground, especially in underserved communities? And what role should the public and private sectors, together with philanthropy, play in shaping these partnerships?
Okay. First of all, for the invite. This has actually given me an opportunity to meet a lot of my friends. So in that sense, I'm quite happy to be here. Nevertheless, I think we are living through very turbulent times. Dr. Guel, I think, mentioned that in his speech. And we've got to acknowledge some things. So the biggest people are giving us lots of money for development assistance for health. The global north countries largely have their own economic issues that they're trying to sort out. As a result, then they have made drastic cuts to the support they've been giving us. So there's a lot of turbulence in that sense. What that means then is that our national governments, our government essentially, should figure out how to handle what was being handled before. So that means that we increase domestic financing. In the Kenyan context, we are saying that we increase domestic financing in the face of a very narrow fiscal space. So this is the national shareable revenue that goes down to counties through the CARA Act. We have the county-owned source. We also have the conditional grants that goes from Ministry of Health to counties as well, among other sources of resources. But we are saying that they increase, but there's also very narrow fiscal space. I think the biggest debate we've been having in Kenya from the last administration and this current administration is the debt management that affects literally everything. So there's that one on one hand. The other thing is that we've got to figure out how do we empower local leadership. So if we are to have solutions for the country, is it feasible that we have then Kenyan faces leading those solutions? And the philanthropies, the development partners then bringing these Kenyans on board to help guide the process. Then we also have to figure out how do we define the roles? Who's to do what role? There's role for the public sector, there's role for the private sector, there's also role for the philanthropies. For example, public sector, one of their main role is regulation. That is a double-edged sword. I'm looking at Frank because he's a chair of KHRAC. When we spoke about regulation, there are a number of regulatory bodies that were brought on board with the Health Act, let's say in Kenya, 2017. A number of these regulatory bodies now have become, I don't want to say rent seekers, but they want to regulate even morticians, you know, so it's quite chaotic in that space. But we need to figure out how do we regulate, how do we invest in infrastructure for public good, that's from the public sector. The private sector can lead in innovation and specific service delivery contracts or service delivery bits and pieces. Katra, who's my very good friend, has alluded to one, the National Equipment Service Program. So you'll find that that's now fee for service. So there's payment for the service that's offered, but the service, the private sector maintains those equipment, they bring cutting edge equipment among other things. Remember, one of the biggest costs when you talk about these capital investments is depreciation costs. So the government can budget, let's say, to put $1 million, for example, in one equipment. Then once it's installed, we lose, let's say, 20%, 15% to depreciation. That's a lot of money that's lost. So you can let the private sector run with that and you leverage on their skills. The philanthropists can bring in money for innovation and scaling some of the things that work and sharing those experiences and lessons learned with other players. That's my submission. Thank you.
Thank you very much, Daktari. So government should regulate and provide the, what shall we call it, the ecosystem for this to grow. Private sector can lead in innovation and in implementation. And philanthropy should ideally provide the money, which brings me to Madame Maureen. This is a conversation we are having. Now, philanthropy has often been viewed as gap filling, yet its potential as a strategic investor in health systems remains under-leveraged. How can philanthropic organizations such as yours evolve from short-term programmatic support to long-term systems strengthening? And what role should they play in advancing national health agendas, national health investment agendas? And even as you answer that, perhaps you can tell us about the work of Gavi and how communities can learn about that work and how they can contribute to the work that you're doing.
Thank you very much. First of all, I totally agree with you that philanthropic organizations are gap filling. And if you look at how and what has happened in the recent times in our health infrastructure, they just walk in and go out. They live within their terms, you know, and they come in with their terms. And one of them that walked out on us abruptly had built their own health system within our country. So you find that they come in with their terms, with their staff, with their commodities. They are actually building a parallel health system within our government. And then when they feel okay to leave, they just walk out and leave. And I think we need to change how we accept philanthropic relationships and our health system that is really protecting the lives of people. So if you look at what we have seen in terms of investment, I don't think it is abstract, it is a choice. For example, the Global Fund, which I coordinate its mechanism in the country, but I also engage in its board as a focal point for communities. Global Fund like for example, in the current funding cycle, they have given us close to 408 million, and only 8.5% of that is going to building our systems. The rest are on recurrent expenditures that puts us at a place where if they leave, then we are stuck. So they procure medication, they offer testing, you know, mosquito nets, but real building of sustainable systems, in as much as they say that they focus on resilient and sustainable systems of health, I think we can do better. So the shift that we need to see is if philanthropy, including Global Fund, becomes a catalytic capital that co-invests with government, not replacing it. So the government should articulate a costed domestic resource investment plan. And it should not be like a condition of the donor, but it should be what the government has as a blueprint. And then invite everyone on the table to put their investments where they feel they're able to, but it should be within the government's blueprint. What we do nowadays is sometimes not that way. We are pushed towards the donor's interest. A good example is that one of them was doing what we call male circumcision, medical male circumcision. Oh, they circumcised. They circumcised until we had no more men to circumcise. They would still give us money and tell us to circumcise men. And we would ask, can it be done twice? You know, like, because it was their agenda that they developed in their capital and not ours. And they were using that for HIV prevention. We have myriad of ways of promoting HIV prevention. So that kind of relationship is what we need to change to be able to take charge of our health system and not leaving it to the philanthropics, but to the government itself. So our government should be smart so that we can move from prescriptive kind of funding and compel them to be strategic partners. Yeah.
I feel like my mouth is open, so I'm going to close it. I want to ask a follow-up question, but I don't think I will. But subject to this conversation, we need to co-invest. It is philanthropy. Should we be accepting all philanthropy? Or should we be directing where this philanthropy is pointed at? I shall be coming to see you about that program. Sounds interesting. Yeah. But to just piggyback from that, if we are supposed to co-create something, Dr. Elizabeth, this is to you. If we are supposed to co-create something, how can we do that? How can we jointly redefine global partnerships to ensure they are not only catalytic, but also aligned with country-led priorities and long-term health system resilience? And I'm asking that now as a real question. I'm going to put on Cherop's Gen Z hat. How do we actually do that so that we don't run out of men to circumcise? And I'm quoting Maureen.
All right, thank you. Let me even start with Cherop. And in terms of the communities are not beneficiaries of, we've called them beneficiary for a long time, but they should be the architects and finally the auditors of what a health system should look like. So that any change that is coming in terms of the priorities actually has the community at heart. And it is possible now to cascade that, what the community wants, now to a global level, having understood what the community wants, and now coming to a country or a county, developing an investment plan, developing a health plan, and that is when other global partners can come and say, what does Turkana need? And I'll paint a very obvious example, since you said I'm from KMPDC. At KMPDC, we have registered close to 17,000 healthcare facilities. Some of the countries interesting, I attended one session by the Saudi. Saudi Arabia has about 500 hospitals. What are we doing with 17,000 hospitals? Because we have not developed a current blueprint. The previous blueprint where we needed to create a health facility every 5 kilometers has been overtaken by events. So we need to develop another one that says, possibly in Nakuru County, we need to stop opening health facilities. Not to discourage entrepreneurs like me, because I'm also an entrepreneur, but to create some level of stability, because even when you come to partnerships and private sector has been left out, private sector puts in money where they can know their risk. For instance, every 5 years, we have new governments, especially at county level, new plans, new county integrated development plans, which don't even sometimes look at what was in the previous one. So some level of stable country plan enables us to form long-term partnerships. So that is one thing. And even now Kenya, speaking of Kenya with 48 different governments, we need also government to take up the role of stewardship and governance very, very seriously. And that is where partners, I know a lot of the health system strengthening work was supported by USA, and some of them pulled out. So there's a bit of level of focus on improving governance and stewardship both at national and county level so that they understand their role in the community. Because Dr. Wangari the other day in a meeting told the minister that he's not the minister of public health facilities. He's the minister of health, yeah? And I do agree, because some level of governance and stewardship, we still have a lot of county or national level focusing more on the public facilities, yeah? You forget that your indicators, if Elizabeth today is running a weird facility where I am killing mothers, those numbers go to the actual county numbers. So there's some level of governance and stewardship, and when you settle that, it enables us to form long-term priorities. And when we develop these policies, we need to develop it with a mixed market thought. In that, knowing other countries, our next door, Tanzania, I think, has more public sector, but in our country, we're almost 50-50. And knowing that, it means that whatever policy we develop has to be able to take care of the fact that we are a mixed market, so that as we write those long-term plans, we are also calling the philanthropies to work more with the private sector. We are calling government to work more with private sector. For instance, even like the MES plan. There is no reason whatsoever why we are not having the MES plan cascaded to the private sector, because possibly their financing arrangements it's easier to negotiate. Maybe private sector can pay a little more, but it's easier to negotiate. And I cannot emphasize the value of a stable policy. Like currently, I know there are some of my practitioners from the private sector. When NHIF moved to SHA, and that is also, it comes also to the community. The way you transition a health system from one thing you are doing to another needs to have some level of buy-in at the community. They need to understand why you're moving and how we are moving. And also investors also need a lot of our facilities. We used to get a lot of investors wanting to come and invest within the Kenyan system because we understood the health financing mechanism. Currently, we are in a transition, notably so, which has reduced the interest from a lot of investors within the Kenyan health system, especially from the private sector side.
Fantastic, thank you very much. The communities, I think the thing that has stuck in my head most is that the communities should be the architects of the program and finally the auditors of it. I don't know what to do with that information that Saudi Arabia has only 500. I feel like I have things to think about when I leave this place. But this brings me to Madame Pauline. You have mentioned the role of private sector. And the Global South is a great example of private sector actually doing the work of government. And we could either choose to accept the reality as it is, and this is reflected in health, and in this country it is reflected in health and in education, or we could choose to bury our heads in the sand. So I want to ask Madame Pauline this question. How can private sector players help reframe global health partnerships to be more equitable, ensuring that African institutions are not just beneficiaries of external funding, but co-architects of solutions that drive progress? And what incentives does private sector need to collaborate with governments, philanthropy, and civil society to co-design these initiatives and these innovative approaches? Only because if it is 50-50, you must actually sit at this table.
Thank you so much, and for a great question, a very complex question as well. But first, let me start by saying private sector is very many varied players, because you got those who are doing direct service provision, and if you look at our numbers of hospitals, you see it's really shared between government, not-for-profit, as well as direct private for-profit entities. But you also have those who bring in other parts. Katra just mentioned the issue of medical equipment scheme, MES, and that was a partnership between the government and a different form of private sector. I come from a different type of private sector still, because I work from a pharmaceutical company that produces medicines for areas of interest, not just to us, but to many others around the world. So it's good for us to think about it that way. But when I look back to when I started working in global health, and I'm not a doctor by training or a nurse, or I kind of just stumbled in here, and then I got stuck, and I loved it and enjoyed it, and I focused very strongly on policy advocacy, and I'm very interested in how accountable systems are. But what I saw was, I think the early years, because I came in the 2000s, it was a level of deep suspicion between private sectors and governments. Then it started to evolve, recognizing that partnerships were necessary. They weren't always easy, and they have never become easy, but I think there's a wider aperture now to have conversations between private sector and government to bring them into policy tables, into co-designing programs. And I want to start there as one of the areas where private sector can bring a reframing to the global health landscape and the frameworks that exist. One is thinking about, we're now in new global health realities. You know, before COVID, we're doing what we used to do. Then I started to hear the term, the new normal. And then now, we're in the post-COVID era, quote, quote, because COVID still does exist, but the impact is a little different. And now we're kind of in the post-free funding era. Allow me to use that very loosely, not disrespect to any entity. But these are the realities that we are confronted with, and that calls for a different way of thinking about how are we going to finance health, how are we going to resource health overall. And so, getting partnerships that are grounded by these realities and thinking about these kind of partnerships do need to bring in equity in decision making, because I think at the core of the partnership is where is the power skewed. I've had people give examples, Maureen gave one, of where things are designed elsewhere and then they are parachuted into the country and you need to implement them. Are they helping you? So equity in decision making. And that doesn't necessarily mean that everything will go the way we want it to, but we come to a point where we can live with the different decisions. And secondly is the issue of access. Do these partnerships help people who need to access healthcare? And finally is the issue of quality. What is the quality that gets brought onto the table? Elizabeth, you mentioned the issue of you can be running a clinic that, it's a contributor to mortality indicators and not health indicators. So how do we continue to ensure that even though we have partnerships, they're anchored on driving quality? And I think really it's, we do need to think about models that leverage local resources. Models must reflect local priorities as well. What are the health priorities that we're working for? And then also to think about collaboration at different layers, at the policy level. I think when I started Global Health, it was not easy to see private sector on the table, at least here in Kenya. Globally, it was a different ballgame. There were more inroads there. But now we're at a place where we actually can have a conversation and say, when you do a policy this way, these are the implications, and look at it more 360 than just one lots of considerations needed. Then, of course, for private sector is the issue of partnerships. Longer term partnerships bring a level of confidence. And you're asked about incentives. How much can private sector be willing to co-invest with governments if the partnerships you are unsure of the length? So the duration matters. Give me a second and I want. Strategic co-creation of solutions. So we have national priorities as a basis for planning and for designing whatever, but we need to co-create strategically so that then it works for the people. And finally is the issue of, private sector looks at risk. I'm putting down my money. What is the risk? Is there any way we can mitigate risk? To what extent can we work with governments to mitigate risk? And people have spoken about interests, leveling the playing field, taking out unfair competition, So then having just clarity of what is being expected of me as a private sector player. You go into partnerships with government sometimes, and then once you've signed the agreement, you receive calls at night. You're now in, once say somebody told me, Pauline, now you're in business because you're working for private sector. It was earth-shattering in my mind. Because when I trusted this person, the entity this person represented was trusted government entity. This ground must be different, not the old ground. Things must be negotiated at the top of the table, and they should be implemented there and remain there. If things change, they need to change in a visible way and for specific reasons. So these are some of the incentives. And finally, I'll speak to regulatory frameworks overall and how they get implemented. There's a lot of uncertainty in our sector on what the regulatory framework will look like. Delays in processes, some feel duplicative and confusing. That is not a recipe for somebody sitting somewhere to invest their capital or bring their company here. It's a recipe for people to hesitate and to question, can we really do it? So we need regulatory systems that are predictable, that we know if I put in a request, 3 months I'll get my answer. If 18 months later I see an answer, what am I supposed to do? Shut my briefcase and go away. So let's not put ourselves as a country in that place, but let's provide the right incentives. Thank you.
Thank you very much, Pauline. That was quite illuminating and brings me to Lucy. You're the technical advisor, Financing Health Alliance for Health. Now, if I had Pauline correctly, private sector now shows up at the table at the very least. Government is compelled from time to time, or all the time, to have them at the table when they're discussing certain things. But if we are to speak frankly, everybody, even guardians, need guardians, right? I think it is safe to say that the guardian of government in a lot of funded activities is the donor. So then I think I want to ask you, how can we go about breaking these silos that exist, the government, private sector, philanthropy institutions, how can we break these silos so that we unlock more resilient and sustainably financed primary and community health systems? And even as you answer that, perhaps you can tell us from your experience working across health and finance ecosystems, what are the most critical barriers that are preventing this alignment, this conversation, this seamless execution? What is causing it? What can we do to prevent it? Thank you.
Thank you. Whenever I'm thinking about the Ministry of Health and the Ministry of Finance, who are the supposedly to be acting as brothers and sisters, I often remember of the story, now this might tell of my age, the river between the two ridges, Kameno and Makoyo. And it's like they're antagonizing against each other. And why I say that is because often, I will start with the barriers that hinder the collaboration between all actors. We find health plans are not budget plans. We always go have our plans, we create very beautiful strategies, but in the absence of the financiers. And then when we are doing the actual budgeting in, for example, in Kenya, we usually start with getting a budget ceiling from the financier, who is the Minister of Finance. So you're told this is how far you can plan. But remember, you even had your plan, which did not consider that. So in the long run, you find we are very constrained to fit in that small box that you've been given. And that's where now the philanthropy, the private sector come in to feed that gap that our Ministry of Finance does not finance. But also, that escalates our problem, and Dr. Ogwell talked of being slapped, because we have been depending on the donors to fill that gap that has been left when in the planning process. And then we go for the donors to fill that gap. But see what has happened. We have been slapped seriously. So the gap, the resource gap has widened in the implementation of healthcare interventions. So another thing that has been existing is we look at health mostly as interventions and health goals. Often do we consider health as an investment? And that is the language that private sector understands. That's the language Ministry of Finance understands. So when I'm going to the Ministry of Finance or to a private partner seeking support, and I'm telling them I need to save mothers from dying, they're like, so what? Everybody, at some point, everybody expires, right? I know it's tough, but it's the reality. But if you go and tell them, okay, see, these are the mothers that we are losing, and this is the amount of money it is translating into a loss. And bringing in the factor of primary health care, where I will use the example of Makueni. I think Makueni is really shining, where in 1 year they spent 900 million to treat cholera when there was an outbreak. And then you remember there are community health workers who have been working tirelessly to reduce this. What if we had very capacitated, that was before the whole program was, the CHP program was running. So what if we had capacitated our community health program, community health promoters? What if we had very good primary health care system where they were able to prevent that, the cholera pandemic or epidemic in the county? We would have spent less than that, let's say half of that amount. So how about you go and tell them, hey, if we are supporting community health or primary health care, this is the money we spent to treat cholera, but if we are able to capacitate and maybe use half of that amount for community health, then this money we will not need to use it, we can reallocate it somewhere else. So I think it is our inability to really demonstrate health as an investment that keeps bringing us back to the barriers that we are seeing, the widening resource gap, and to say Kenya has one of the best systems. When we look at PFM, and I like what my colleague said about implementation of in the counties, we are seeing when we are looking for more resources, the Ministry of Finance or our financiers will first ask, we gave you this money last year, but the implementation, we only executed the budget to around 80%. So why do you need more money if you're not even exhausting what existed? But then when you look at the system itself, she said it, that money is released late as 25th June, and you're supposed to be reporting on 30th. So what do? That money will have to come back, and it will be seen as underperformance. So those are the consistent barriers that we have seen. And to unlock more funding for primary health care, we don't need to go looking elsewhere. We just need to start within what we have. It's addressing such barriers of delays in the release of funding so that we can ensure that our health services are running smoothly throughout the year. It is closing the gap of wastages. And I love Dr. Ogwell. I think he was reading my mind when he was talking about the wastages. We're seeing across Africa an average of between 30 to 40% resources are wasted annually goes into wastages. So we're looking for more money, but the paved ridges, it's like we're pouring in a bucket that has holes. So how do we close these holes first, even before we go to look for more resources? Because the fiscal space is very limited. I can tell you, even if the Ministry of Finance or the Treasury was here, they will tell you that we don't have more money. So it's us to innovate within what we have to be able to bring out the resources clearly. Thanks.
Thank you very much, Lucy. I think listening to all of you, we're all saying the same thing. You all agree, and you're all the policymakers. So I'm going to ask the question I've had since I sat there. I'm going to ask the question I've had since USAID closed. And we start hearing HIV this and HIV that, and everything is going backwards. And then last week in the news, you know, as we were all minding our God-given business, we found out that a few monkeys had run amok in the States, and they were carrying COVID and a few other things. So it may be safe to assume that at some point, one of those will find its way here, because people travel, God forbid. But in the event, so we have to look at a doomsday scenario of sorts, right? So I'm going to ask you, Ms. Maureen, and I'm going to ask various variations of this question to all of you. If global commitments to replenish the global fund fail to match the scale of Africa's health needs, or maybe I should ask, when? Because it has happened, yes? What are the immediate and long-term risks for countries like us? And how can you all seated here, representing the organizations that you do, mobilize to prevent a reversal of very hard-won health gains? I'll start with you, Maureen.
So I think for us, the stakes here are around clarity and trajectory. Do we even know what we will lose if we don't get any more of Global Fund? Do we have that data somewhere? And when someone was talking about data, we heard that our data is interest-based. Yeah. So do we have honest data that we can say, this is the loss we will get if we don't get Global Fund?
Who should we be asking for that data?
I don't have the answers. So, so what frontiers are we protecting, and what are we building next? I think for us, we need to protect the hard-won gains against the 3 epidemics. We need to now start thinking efficiency. Sometimes you see so many vehicles running around, from the project, vehicles running, they have drivers. And one example, we were given money to strengthen disease surveillance. That was after COVID. We bought 47 more vehicles, one for each county, high-end vehicles. And you're looking at yourself and you're thinking, is this what we really need?
You are upsetting me on a serious.
And then the second one, we need to strengthen the systems that will sustain us beyond the donor.
Okay.
Yeah.
All right.
And then finally, we need partnerships that look at Kenya not as a beneficiary of donor funding, but an architect of Africa health security. And to get here, like everyone has said, we must stop wastage, we must be efficient, we must be led by data and not interests, and then there has to be some political goodwill. Yeah, thank you.
I think I will go to Madame Katra next. If that fund is not replenished, what is the COG? What will the COG be doing to help strengthen these systems so that we do not go back to where we came from? And while we are there, perhaps you can help me understand who is supposed to have data.
Thank you so much. I think I'll start this way. First of all, let us appreciate, all of us, let us appreciate that we are not a very poor country. We are in a middle-income country. We've been classified, so we are there. So this issue of actually relying so much also on donors is what is killing us. As a country, we need to get our priorities right. Our priorities are upside down. Secondly, when we were caught off, we were basically caught naked when the stop order from US government came. And things were helter-skelter. Nobody was prepared. Everybody was running helter-skelter. As a country and as counties, what we immediately did is to basically integrate the services, to seal the gap. Because we immediately took stock of the number of healthcare workers who are affected. There are close to 11,000 healthcare workers who lost their job. And we were relying so much in terms of HIV drugs. We were relying on US government in terms of data and what and what and what. At a point, even we were told that we have to download our data from the system because it was managed by somebody else. I think it is the right time we need to get our priorities right. It is the right time we need to give our country what it is required, and we need to properly budget and allocate adequate resources to some of the, basically health sector, let me just say health sector, because if you don't have a healthy population, then you have sick population, it will be very expensive for you to manage, and basically the economy of the country will basically go down. So what do I say? For us, I think that has really opened our eyes. We have to really strategize and see what can happen. There have been so many implementing partners, and most of the time, we don't take accountability. Nobody is holding them accountable. I'll just give you an example. In terms of maternal newborn health, we have 101 partners who are basically in that space. But when you look at our indicators, we are still where we were in terms of maternal death. We are not progressing. So what is not right? What are we not doing right? I think it's high time we need to re-strategize. We need to sit on a table where actually anyone who sits on that table can give us an action point that is workable and that we can be able to implement. But as counties, actually we are trying to re-strategize, and that is why the FIF thing came. That is why we are trying to do a lot of domestic resource mobilization. That is why we are even telling the partners, as you come, this is our priority, we don't want your priority, come and align with us. What usually happens is like partners come with their own priority. Probably that priority is not my need. I can see the chief officer of Muranga is seated here. A partner comes to him with already an envelope that this is what we are going to do, this is what we are going to do. It is high time we say reject. What we need to do is basically sit. This is our county integrated development plan. This is how we plan. This is our priorities. If you want to align with us. If you don't want, that is it. So that we get our priority. That way you can even sustain. I know right now when you look at the collections of FIF, even through SHA, counties have really benefited, most counties have really benefited on SHA. It's a very good concept, by the way. Like the level 4 even which never used to receive monies are now receiving a lot of money. And my director here from Nakuru is seated there. There is a time, I think it was early this year, Nakuru County was actually top on the newspaper, generating a lot of money through FIF. They collected a lot of revenue. So even if like a partner was there and he basically received, they have no problem. Because they have their money, they can be able to chip in and get their priorities right and ensure that services are running. So as a country, we are not poor. Let us just get our priorities right. And for us as counties, we will ensure that the gains that have been made will not be lost as a result of this. It is high time that the counties also need to come together. The regional blocks need to come together. For example, we have counties classified into regional blocks. Like we have LREB, Lake Region Economic Block, which is very active. They are coming together, that is 14 counties, putting their resources. They are doing a pooling of resources, putting their priorities right. What do we need as, for example, Lake Region Economic Block? Our gap, for example, in terms of health is high burden of HIV. So what do we need to do right? You come to SEREB, probably there's an issue of non-communicable disease. Pool your resources together. What is it that we need to do to address this? Because that is where you are that's where you are hit hardly. So I think we are not a poor country. Let us go back, start farming, get our priorities right, and do the right thing. And make sure at least learning from this lesson. My sister here, we sit with her in KCM. She's very active, by the way. There's a time now we need to say, please now Global Fund, pause a bit. We have money. I don't know when we'll reach there. Vision 2030, Vision 5050, I don't know. But that is where we should be heading to. Thank you.
Fantastic. I think I want to wrap up this session. I will give everybody but Katra and Maureen an opportunity to wrap up in a minute or less, and it's around what are we going to do. You commit to what you will be doing.
So, what we need to do. One, we need to start with allocative efficiency. Let us seal the holes. Let us see what do we have. How best can we make use of what we have? We're not going to look anywhere else. So let's implement the one plan, one budget, one health. Because remember, if the Ministry of Water is not working, then cholera will come to us. Actually, health is the face of a failed system because we are recipients of all sicknesses, of everything. So when all systems fail, we are the ones that suffer. So let's bring all our resources together from all ministries, from any department that touches on health should contribute towards the kitty. So one plan, one budget, one health. Thank you.
Thank you. I think for me is to understand where we are at and to know that the time for speaking about Abuja Declaration and drastic increases in health budgets will not, it's over. Because there's no way we are struggling with it and you're going to ask for an increment in budgets. So, and that is why we have to leverage on other ways of financing health services, including blended financing. There are a few things here and there that has been tried across the world. So can we look at what is possible? And I love that Madam Katra is talking about the regional blocks. Can the regional blocks come together? See where the risk is, where aren't people investing in maternal health, take up that risk so that when a private investor comes, you have actually lowered the risk so that we can have more money within the health system and of course, to spend it well. One last thing for government and for policymakers is to provide market insights. For a lot of private investors, for them to come in, must know how your market is. And as I think I've heard of Makueni, when they gave an investment plan and said, this is what we lost, this is the opportunity, people are able to come in. So if all the countries and counties are able to provide this market insight of what is the opportunity within their regions, we are going to get much more money. Thank you.
I think the panelists have actually covered the things that I want to say. The only thing I'd want to say is that we'll get the money from government largely. So that means that everything must be on budget. We can't be having a support that's coming off budget. I think that's the biggest thing that has been bedeviling us. So if the support that comes in is on budget, then it's much to track the impact and the effects of withdrawal of those resources. Thank you.
Let me give you a quick example, and I'll draw my final ones. I am working for a program at Pfizer called An Accord for a Healthy World, and that program, Pfizer made a decision in 2022 to provide all of its portfolio of medicines and vaccines at not-for-profit to 45 low-income and lower middle-income countries that graduated less than 10 years ago. So there is a cut for lower middle-income countries, and for Kenya falls under that. And the decision on the medicine or vaccine you want belongs to the country. We come and have a conversation, then we get you into an agreement process. But in addition to that, we also are looking at health systems and where we can play around supply chain, strengthening regulatory, but also improving medical education and skills. I'm giving this example because it's a new way of doing business, and it's a new big commitment at scale, 45 countries. Other countries have to make decisions. So where I'm heading with this is, it's important in this era for governments to leverage opportunities that lie beyond the donor funding model that pre-existed, and that's kind of winding itself up, to look into new ways of partnering and to provide the opportunity. and to see, how does this serve my people? This example, for example, cancer, the PS highlighted it as a major challenge here. We got a very robust portfolio of cancer medicines. If you look at it not for profit, there will be surprise in terms of savings. The program was launched in June, but now we need to move to implementation. We, on our side, we're doing the health systems work, but we need government to invest in procuring the medicines, because we moved away from donations. Donations, we give you worth 200K, we go away. Still gonna need to continue people. But what about if you plan, I'm going to put 50,000, and then I'm going to put 100, and I'm going to grow it up to $1 million in 5 years or in X number of years. The government then start to normalize spending own resources by leveraging opportunities that exist. So leverage, 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 but also make the environment workable for private sector. Thank you.
I think I'd like to close it at that and to say thank you very much. It has been a pleasure moderating this panel. I have learnt a lot. I think the two things I've taken away is that where you live, which is Africa, should not determine whether you live or die. And whether we will live or die is very dependent on what we do next. So I hope the funders in the room can gather. We have found out today that we are rich. We just pilfer a lot. So perhaps to meet us all and to draw up that policy that helps us not pilfer and points resources in the right direction. Thank you very much to all of you, and thank you very much for listening.
Thank you so much. So there are a few comments from our online audience. So there was June Victoria. There should be a working group for identifying vulnerabilities and risk reduction strategies while promoting multi-sectoral collaboration, because health is cost-cutting. Thank you, June. The final comment was from Rose Wandia. Inefficiencies are the biggest problem, not lack of resources. It's a fact. Donors come to supplement, not replace government responsibility. It's the government's role to guide, co-design, and strategically allocate resources to sustain core service delivery. When philanthropy fades, government must step in, not step out. Yet too often, government checks out when donors check in. We miss opportunities to timely align interministerial resources, engage the private sector, and use health data for smart decisions. Transitioning demands leadership, not delegation. Thank you so much, Rose. You've been really active the whole day. At this point, I'd like to call back Professor Wafula on stage. We have a small token of appreciation. Yes, Professor Wafula, yes? Yes? Dr. Wangoi. Dr. Wangoi, I'd request you could issue this token of appreciation on behalf of Strathmore. A round of applause as they receive their gifts. Thank you.
Thank you very much. We are ready to, on behalf of Strathmore and all the partners for this forum, we'd like to thank the panel for sharing your thoughts, for being very open, and for being champions for Kenyans. Thank you to our moderator, and thank you to everyone who's been here the whole afternoon for being bright and energetic. We really feel your vibrations here. And we've got a little something for the panelists before we leave. Thank you.
of applause for our last panel for the day. Really, really ending it in a very high note. And thank you to even our moderator for that session. And as Prof. Frank, they're finalizing, there's still discussions. But I think we can all agree that in line with the theme for today, we've had our speakers really making the case for sustainable health financing. And I think to wrap it up, and I know we're slightly over time, I want to hand it back to the Strathmore family. Once again, thank you for hosting us at this prestigious institution. Very strong alumni. I am motivated to submit a form. But I'm going to hand it back to you and your team to wrap it up for us and give the closing remarks and also the way forward. And thank you.
Wow. The day is coming to an end. I feel a bit sad. So when I was asked to take 5 minutes to give closing remarks, that's such little time, considering we have roughly 6 hours of recorded conversations. So I wondered, what's the best way of doing this? How do you take 5 minutes to talk about something that was discussed for 6, 7 hours? It's crazy, isn't it? And then I remembered I'm an academic, and you guys are going to come here and you leave here without any frameworks or any theories. I said, no, we are going to fix that at the close. And so what you have there is an interesting framework by a gentleman called John Kingdon, which most of you who are policy students must have come across. So that's called Kingdoms. It's not kingdom like the British kingdom. There's an N at the end. Nairobi, Niger at the end. So Kingdom's three streams model is a very interesting concept that talks about what is the opportune moment for policy change. And John Kingdon, in 1984, I'll let that sink in because I think maybe 90% of you here, well, maybe a little less, may not have been born. John Kingdon argued that there's 3 independent streams that run. They are completely agnostic of what's going on around them, and they just kind of do their own business. They are blinded to what's happening around, and this is the problem stream, the politics stream, and the solution stream. You can see them there. Occasionally, 2 streams meet. There's a little change that happens. So for example, when the policy streams and the politics meet, there's a small political window and you'll see a small change. Occasionally, the problem stream meets with the policy stream, and there's a problem window, and people start discussing about the problems that are there, because it's been brought to the purview of the policy stream. But once in a blue moon, that night when the werewolf comes out, all of you have watched those nice movies. Once in a blue moon, the 3 actually meet. That's so cool, isn't it? Yeah, so when they meet, they form what we call a policy window. Now, what's exciting about 2025 and where we are now, I genuinely believe the 3 streams are meeting. I'll tell you why. We started in the morning. The first session and the first panel was basically talking about the challenges, the problems that we have. We had the problem of aid, withdrawal, or rather, as I'm reminded, aid being repurposed, reusing and being repurposed. And thank you for reminding us. We still have philanthropy. We still have the Global Fund who are holding our hands. So aid is actually not being eliminated. That's a very important corruption. It's reducing, but being repurposed for impact. So there's no more free money. People are buying results now. That's a very, very big difference. So as aid is reducing, that's a problem. We heard about the problem of fragmentation within us, our systems. That's a clear problem. We heard about the mismatch between the solutions that we purport to be offering and sustainability. And the PS talked about that quite a lot in the morning. You are giving dialysis to people just enough to keep them going back next week. Sorry, in 2 or 3 days for the next dialysis session. We heard about inefficiency and waste, and that was brought out very strongly. Are we actually investing in the right place, in the right areas? And then we heard about inaction. And somebody looked me in the eyes and told me, we've been here before. In fact, this meeting looks very familiar. And we're not doing much. So we had all the problems. And then we moved on to look at what's the politics behind this. And I think the PS again started this conversation, and it's gone all the way up to now. So the first thing we had is health is a driver of the economy, but we don't say that enough. We were told about us people in the health sector asking for inputs, and that's actually very true. A few years back, I was one of the specialists within the World Bank Group, and one of the things I was tasked with doing at the time was to lead the initiative that developed the first ever public-private partnership strategy for Kenya. One of my proudest moments was the day that document was officially signed by the cabinet secretary and launched. So we actually have a public-private partnership strategy for Kenya that we finished working on in 2020. But that's not what I'm talking about. What I'm talking about is the fact that we spent a bit of time at Treasury when we were working with that document. This is the first time I actually interacted with Treasury people, officials between 2018 and 2020. And one thing I've never forgotten, the PPP directorate back then, it was called the PPP unit before the new act. They remember telling us, we don't like you people in health very much. I felt a bit offended because I said, but we are the good guys. Like, we are the guys who solve problems, disease, and all that. Why don't you like about us, I pray? And he told me it's because, and he actually showed me a sample of requests that come into Treasury with a budget office. The gentleman from the budget office, I can't remember what it's called, PBO, was actually there, and they actually said, these are the kind of inputs you get from the health sectors. I looked through, and he told me, what are you looking at as a summary through the templates? Because that's how they put them. They put everything we take into a template. One thing that came out very clearly is people in health ask for inputs. People from road buying results. When they talk about an A4 road, they actually talk about the direct economic return. They talk about lives saved, and then they go on to quantify those in terms of contribution to the economy. The only sector that had inputs was healthcare. And it was very sad because they were saying, WHO says we need 1 doctor per X. We need money to hire 2,000 nurses. We need money to hire. That is how the requests were coming from healthcare. Hiring people, building structures, inputs. And he said, that's why we don't take you people seriously. Because, why should I invest there when I actually have a very strong case on how I can build my economy if I took an extra 10 billion to roads, to housing, and other sectors? So I'm glad that came out. The politics. We need to start talking about the value that health actually delivers. We are not just saving lives. We are building the economy, social and economic development. We talked about how do we make impactful health innovations more appealing to politicians. At the moment, the politicians have a lot to go by. Building a new structure with their name on it, launching equipment, launching ambulances. They're always launching something. How can they start launching services? How can they start launching improvement in household because CHPs are working? We need to innovate around that. We talked about data as a political tool as well. That was part of the politics. Whoever owns the data, whoever shouts the loudest using their data, they're the ones who get their issues up the agenda. Sometimes they're not the most important issues you're dealing with. And then we finally talked about the global health politics and what does it mean. Kenya is strategically positioned. The strongest resource in Kenya is actually its people. Our roads are pretty bad, most of us have to admit. I don't think, we're not doing that great when it comes to infrastructure and a lot of other things. The one thing that I love here are the people and the level of engagement that we have. Kenya, Ghana, South Africa, Ethiopia, you are seeing Africa having this growing young population of brilliant people. How can we invest that and make it work for us? And last but not least, after talking about the problem and the politics, we started seeing solutions emerging. One of the things that came out was just immediately, can we start talking about how do we frame all these things that we are doing into something that is actually actionable? I was challenged by Dr. Theuri to talk about, to do a white paper. We've done white papers before. I think it's great to have a white paper from this session. What is it about it that can be actioned? When I was walking P.S. Oluga out, he actually told me he's very impressed by the quality of discussions that he saw here. And he challenged me, can we have a debrief with him because of that platform he's trying to put together that basically aims at creating better synergies across the system so that the results can move better. He actually challenged me and he said, Frank, I will not forget that. Please let that grow from here because we are struggling. We know where we want to go as a ministry. We have the vision of what we need to do, but we want to figure out how can we get the right process so that even as we are moving all these investments, we are moving them in a way that's acceptable to a wider audience, the way we are doing here. I took up that challenge, and I feel that is a solution that could come out of here. We talked about structured approaches to PPPs, and particularly the important role of government as a steward. I know private sector is exciting, they have innovation, they do things quicker, but the truth of the matter is I have very little evidence, and we do a lot of work analyzing PPPs. I've seen very little evidence of private sector thriving in areas with weak government stewardship. How do we support strong government stewardship? At the end of the day, the government is still the legitimate body to actually provide the direction and provide the guidance. The private sector can drive a lot of the development, but we need to support government in its steering function. Let the private sector play the rowing function, that's great. Let us support government to play the stewardship function. That's how the ship moves. And last but not least, the issue of what is the transitioning role of development partners, particularly philanthropy organizations. I suspect you're going to see some changes. You're going to see a lot of government-to-government funding now. You see a lot of middlemen being kind of washed out. But the interesting thing is, I suspect, and I predict that we'll have a very important catalytic role that funds from development partners, particularly philanthropies, will continue playing. Do not take funding from philanthropies like the Gates Foundation, MasterCard Foundation, and others for granted. I feel as Africans, we took a lot of aid for granted, and we did not use it well. Philanthropists do not have the kind of patience to see wastage that perhaps some of the bilateral partnerships could have had because of the sensitivities of government to government. Let us take advantage of the catalytic support that is there to demonstrate results, to invest in the right areas, because one day they could also go if we continue doing things in the wrong way. And as I finish this, I want to emphasize that to me, one of the biggest failures of development assistance execution, and that's our fault as Africans, was we focused on what is called health system support rather than health system strengthening. What's the difference between these two things? Health system support is, I'm a donor, I'm supporting HIV, so I'm going to provide training, but I'm only training people who are dealing with HIV patients and stuff like that. I'm going to support infrastructure, but I'll build a very nice corner that's called a CCC somewhere, and it's going to be my place. That's health system support, doing certain vertical things to help you achieve your results as presented in your performance monitoring framework. Health system strengthening means you completely ignore what is working to your advantage directly, and you look at what does it mean to have an entire system working well, a rising tide that's lifting all boats. Which means, even as philanthropists, even as investors, even as scientists who are in this room, we need to now start curating models that are based on elevating the entirety of the health system, rather than elevating the areas around your programmatic interventions that lead to you reporting the results very quickly. Because that is the difference between a solution that is not sustainable and one that can actually deliver sustainability. Otherwise, we end up with a situation where we are over-circumcising men. And what happens when you run out of men to circumcise? I think the men in this room start shuddering because they wonder what happens when you're asked to go for a second round of circumcision. And they don't want that because most of them still have some trauma from the first round. So let us avoid falling into that pitfall of over-reporting certain results, focusing on very narrow areas, and instead look at these more horizontally. That is the summary of the discussions we've had, and I really want to thank, I owe this to John Kingdom for taking time to create a model that simplifies an area for policy change. Inside there is somebody called a policy broker, and I'm going to argue that academic institutions, including Strathmore, where I'm faculty, and University of Nairobi, where I'm still adjunct faculty, those two institutions are close to my heart for many reasons. These institutions can play a very important role in catalyzing the kind of positive change that you want. So thank you very, very much, but I want to invite Mandela to basically give the vote of thanks. But on behalf of my colleagues who kind of were part of this planning process, and our funder who supported this process. I think the Gates Foundation, Doreen and the team, you've done an amazing job. We just want to thank you for making time to be here. Thank you for those who are online as well. And we look forward to taking these conversations forward. Mandela, over to you.
Thank you so much. A round of applause to Prof. Frank. It's very hard to come after a professor who has said a lot. So I'll just take a few words, and as we come to the close of today's Health System Forum, allow me on behalf of Strathmore Business School to extend our heartfelt gratitude to each of you who made this gathering such a success. To our distinguished panelists, moderators, and keynote speakers, thank you for your thoughtful insights and bold perspective. You have sparked vital conversations on how we can strengthen Africa's health system amid changing realities. To our partners and collaborators, we are deeply grateful for your commitment and partnership. The Gates Foundation, the Kenya Healthcare Federation, the Ministry of Health, the Council of Governors, the Office of the President, the World Bank, LVCT Health, the Christian Health Association of Kenya, the Global Fund, the Beginnings Fund, Savannah Global Health, JPEGO, PS Kenya. Your collective leadership and investment in Africa's health future are not only commendable but essential in the resilience you all seek to build. A special thank you also to our organizing team, technical crew, and support staff for their seamless execution and quiet dedication throughout the day. Colleagues, today's discussions reminded us of one thing: Africa's path forward lies in the dependency, but determined self-reliance. We must continue to strengthen partnerships, public, private, and community levels, invest in innovation that adapts to our realities and amplifies our local solutions, and lastly, champion sustainable health financing that protects our people, generations to come. These conversations we've had today must translate into action in boardrooms, in county assemblies, in ministries, in hospitals, and in communities. Let us live here as champions of implementation and not just inspiration. On behalf of Strathmore Business School and all our partners, thank you for your presence, your passion, and your commitment. Together, let's move Africa's health system from resilience to renaissance. A round of applause to all our speakers. Thank you for being with us all through the day. Not forgetting our panel moderators, that is Doreen. A round of applause to Doreen as well for guiding us all through the day. So see you next time. Let's have the conversations. There's a lot of tea outside. One thing at Strathmore, there's a lot of eating. So please, there's a lot of tea and a few snacks. Feel free to continue the conversations and have tea. For our online audience, thank you so much for guiding in, dialing in all through morning, and do have a good evening. Thank you so much. Let's go for tea. Tea is outside at the atrium. Let's have some tea as we continue the conversation. Thank you.